till this time? Holy moly! That was so hard. Sorry, guys. I'm just doing a super quick, clicking a couple things. Give me 10 seconds, all right? I'm clicking important stuff. Add flare, NREMT, post. Give me a second. This is my first time doing this. Let me make sure that I'm live. Let me make sure I don't sound bad. Oh gosh, there's an ad. Oh, I see it. Yo, yo. Hey, thanks so much for the cool videos. And there's Cool Breeze. A lot of love from, I love them all. There's Jose, there's Robert. Fellas, I see you. I see your messages. They're very sweet. This is my first time doing this. So I got my computer set up right there. I think that's the only way I can read messages. Hey, it's the guy that helped me pass. Clark, we love to hear that, Clark. How is my audio? I can't tell because this ad won't get out of my way. Let me see. Okay, this audio sounds kind of crisp. Are we all in agreement? This audio sounds pretty good. Also, I set up at station 73 today. It's good. Thank you, Robert. I love to see that. We're gonna have a lot of fun today. So I brought a bunch of different skills pertaining to EMS. I have everything set up right now. Good for an IRL stream. Audio is good. Beautiful. Beautiful. We love all those comments, guys. As you can see, we've got a beautiful airway mannequin we're going to explore later. We've got a CPR mannequin here. We have a whiteboard, some skills. So I'll leave it up to you guys. I've got just about everything. I've got my EMS protocols here. Oh, geez. What's something that you guys want to touch up on? What's a question that some of you guys have? I'd love to answer it. Any update on the new NREMT test? About to take it soon? Great question. So, for I think is Robert like my old captain? Oh, geez, I hope not. That's fine. The new NREMT. Yes, so it changed mid-April. A lot of students are really worried about it, but trust me, guys, that study guide review that I have posted up, it's still very efficient, and I think it'll help you guys out a lot. I've been hearing every day where people will message me nice things. I get like 3 messages, 4 messages at a time that I say, "Oh, Mario, using that study guide, I ended up passing my national registry." The AC is broken, by the way, guys, so there's going to be a lot of sweat. Uh, so I think you'll be in good hands there. I'm working on a test bank. It's not done yet because my LLC got kicked back because of the name I chose. It wasn't a profanity name. So we're gonna have to wait a tiny bit on that. Let's see. We got an airway mannequin like that at our school. Passed my NRMT this week. Thanks. That's what I love to hear. You know what? Let's just get on with it, right? So we're gonna talk about a cardiac arrest and some of the things that we want to consider. And I think we should just go from there. So we got our mannequin here, our beautiful mannequin. And we're going to look at this from multiple perspectives. So we'll start with an EMT. What does an EMT do if they suspect that somebody has cardiac arrest? In fact, if anything, let's say I walk up on the scene, I pop up. Uh oh. Uh oh. Do not disturb. Why is it not available? There it is. Is it still good, guys? Is it still good? That sounds good to me. That still sounds crisp. Okay. So you show up on scene. You put on your gloves, you got your paramedic buddy, but let's just say right now that you are an EMT by yourself and you have a patient that's unconscious on the floor. What's some of the things that we need to do as an EMT? Well, the first thing is we need to assess their mental status. So, what I like to talk about, guys, that not many people mention is we don't get calls where people are just laying down on the floor, right? There's also there's a reason why we came out. It's usually because there's a bystander or somebody calling that says, "Hey, I need help. I need 911," right? So they contact 911 and then we show up. So maybe we have a bystander on scene, right? And we can ask the bystander a couple of things. Hey, how long has this been person been going down? Did anything happen beforehand? Did they fall and hit their head, or did you kind of carry them down? Are we on a bed? What are we on right now? Right. So we're going to play devil's advocate, though. Let's just say we had a wellness check and they contacted 911 and we have an unconscious person here. Uh, they aren't presenting with signs of obvious death, right? And so, what do I mean by that? They don't have any pooling in the back of their back, right? They don't have a stiff jaw. What I like to do is a jaw test where I'll grab the person and I'll jiggle their jaw a little bit. I'll be like, oh, jaw stiff. They're probably dead. Let's take a couple other looks here. But their jaw is pliable. That's what we like to see. So just making sure. CABC, critical, bleeds, then ABC. Good advice. Good advice, Robert. So I'm going to go up to my patient. And if I'm an EMT, or for anyone, I'm going to go down and I'm going to assess a couple things. So I like to put my fingers on the carotid artery and the radial artery at the same time. I go down and I listen for breath sounds and I look for chest rise. Now, if any of you have been in a cardiac arrest call, you may be thinking, oh, Mario, I practice this in class all the time. I go down, feel a pulse, that's it. In real life, it's very challenging to feel a carotid pulse, in my opinion. Now you get better at it over time, or feel a radial pulse. Sometimes you're going to be there for 5 minutes, 10 minutes. Yeah, or not 5 minutes, 10 minutes. It's going to feel like that, maybe 20 seconds, 30 seconds. And you're like, I think he's dead. I don't know. Is he unconscious? Things like that. Don't underestimate listening for breath sounds. Don't underestimate looking for chest rise. If I don't hear any breathing, if I don't see any chest rise while I'm trying to feel a carotid radial pulse, I can't feel it. It's a go to that I need to start compressions right away. And that's usually my go to. So before I start chest compressions, I've got to think of a couple things, right? I have to think, uh, where is my patient at? Right here, he's on a table. That'll work really well. But if that's not the case, then I need to move them from the bed. Maybe I need to get my partner. We're doing a life over limb. So we're dragging our guy down. We're getting him onto a hard surface like this table right here, or let's say our backboard, the floor, and we can start working on him. At the same time, if I'm working with a partner who's an EMT-B, I might tell him if it's available, hey, let's go ahead and call ALS Intercept, see if they can get on scene. Let's request ALS support. Maybe we're two EMT-Bs, but a paramedic's 5, 10 minutes away. They can do a couple more things that we're not able to do depending on our jurisdiction. So we're starting CPR, right? And we'll start. Oh, geez, this is not a good surface. All right, all right. Is this a better surface? Oh, let's take a little look see here. This is not how you should be performing CPR. You should be past the person. Basically, whenever you perform CPR on somebody, you should be leaning over, you should have your shoulders right where your hands are at, and you want to cross your hands like so. We're going to do it on this surface right here just because it's a little bit easier for me. And when we compress, we're also going to let recoil occur, right? So we're going to compress. I don't want to break this thing, so I'll probably stop right here. But we have somebody doing adequate chest compressions. At the same time, our partner is requesting ALS intercept. You know what? In real life, yes, in textbook, we want a BVM or bag valve mask set up right away. We want an AED set up right away. But in real life, sometimes we have to do chest compressions for a good 30 seconds, a minute, 2 minutes, or not 2 minutes, but 30 seconds to a minute, or we're just doing continuous chest compressions. That's okay. So we're doing continuous chest compressions. My partner should be gathering the AED to set up on my patient. I would do something where I'm not going to lift up his shirt, but we would want to slap it on right here, right here. But before that, we also want to get a BVM or bag valve mask. So I'm going to pull that out. Let's see. Have you ever done double sequential defibrillation? What the heck is double sequential defibrillation? Buddy, I have never heard of that before. That sounds very cool. Uh, where I guess you shock at both sides like a biphasic. Okay. I don't want to break this because I don't want to get in trouble. Let me just rip this open. Let's see here. So what we have here is we have a bag valve mask. I'm going to show you guys a tip some of you guys may have learned in school, but you may have accidentally glazed over it. Okay. So we have a bag valve mask. This is how we deliver airway or breaths to an unconscious patient in EMS. So what I always recommend people to do is to perform the C grip and the E grip. Okay, it's very important. So if I'm the person breathing for the patient, and let's say I'm used to doing it in the classroom. Can I scoot in a little bit? There we go. I'm used to doing this in the classroom. And so whenever I go to an actual unconscious person, I'm like trying to put the C grip around, and then I'm like, why isn't it working? Why isn't the E grip working? If that happens, you know what I normally do in a cardiac arrest? I flip around, I do the C grip on this side, and I put the E grip like so. And then I've got a great manipulation of his jaw. So if we flip this guy over here, we can see the C grip is forming around the mask, and then the E grip is grabbing the jaw like so. And I've got 3 fingers here. That lets me create a complete seal over my patient. Let's see. Two defibs, you pop them one after another. It's when you have two defibs. Wow, God, we love the pit. I don't know what the pit means, but that sounds insane doing two defibs at the same time. I've never heard of that. That's crazy, but that's very interesting. I would love to see that done, but I might panic if I see that intrinsically. So anyway, whenever we give a breath, we want to control the jaw. We want to do two breaths, and when we do our breaths for our patient, we're not squeezing the bag as hard as we can. And we don't want to do that because we don't want to pop a lung. So instead, we're gonna get our 2 fingers here, 1 finger here. We do a nice little squeeze. We're gonna squeeze the bag about 1/3 of the way, right? And that's what I like to do whenever I work on a CPR call if I'm breathing for the patient. So I'm gonna administer 2 breaths. One, two. And I take about a second for each one. Then we go right back to CPR, right? We're gonna continue our compressions constantly. Is it loading? Whatever, or buffering. It's a medical drama on HBO Max. Oh, I've heard about it from so many different people as I'm bringing in patients from the ER. Anyway, so we're doing our compressions, right? We have our AED set up, and our AED is going to tell us one of the two things. It's going to say shock advised or shock not advised. And what does that mean? So if our AED advises us that the shock is not advised, it means that they're having one of two rhythms. They could be having a systole, or they could be having PEA, which is also known as pulseless electrical activity. Okay. Those are not shockable rhythms, but we should still continue working on cardiac arrest whenever we have a patient who is in a systole or pulseless electrical activity. Just because the monitor tells us not to shock our patient, that doesn't mean that they're dead. Okay. We still need to keep working on them. And you know what? There's a small chance that maybe we actually brought them back from just adequate chest compressions, or maybe they just weren't dead in the first place. And we're going to talk about that weird intermittent cycle as well. So it looks a lot better on my computer than my phone. Whatever. Anyway, so we're doing our chest compressions. And let's say it says shock advised. Well, what's going on? Well, if that's the case, then it's going to be a ventricular rhythm. So more than likely, it's either going to be VFib or VTAC without a pulse. Those are our two shockable rhythms. So I'm working my CPR call. My partner is bagging for my patient. Everything's going really smooth, right? And then it says analyzing rhythm. I'm going to keep my hands off my patient. Okay. It's going to say shock advised. Okay. As soon as it says that, start CPR. And then it's going to say charging, right? And this isn't good compressions, but I'm on a table right now. So give me a break on that. Anyway, it's going to say shock advised. Continue uh, doing compressions as it says charging. Until the light flickers orange, you're gonna, or whatever color it is, keep doing great compressions, right? Because we want to fill up that heart before we administer a shock to send it off in the system to restart it, right? So it'll say press to deliver shock or something along those lines. Okay. At that point, you stand clear, you look at your partner stands clear, everyone's got their hand, everyone's going to be staying clear, everyone's going to be watching each other. And then We're going to go ahead and press the defib button. As soon as we do that, we immediately start back on chest compressions, okay? We're not waiting until it says shock delivered. Continue CPR. You see all that unnecessary time that we're losing there? We need to start compressions immediately, right? And I'm going to read these comments and then I'm going to answer or tell you guys something really interesting. I was told to squeeze the whole bag, but I was told not to do the whole thing because the bag delivers. That's a great point that you're bringing up there. Who's that? What's that name? For Santi Hernio or Hana Hernio. I apologize if I didn't read that right. So, my best advice to you, of course, listen to your instructor and pay attention, is to use two fingers here and one with your thumb. You're going to squeeze the bag 1/3 of the way. Okay. You see how I'm doing a very light delivery every time I do a breath? If we squeeze too hard, you got to think about what we're inflating. We're inflating lungs. And if we inflate too hard, we might potentially burst a lung. So luckily, I've got a great airway mannequin here, and I'll see if I can get a better shot for you guys to visualize it. Because I'm going to hone in on that question. I'm going to read some more comments afterwards. So we'll tilt it like so. That should give you more or less a pretty decent visualization of it. I apologize if it's not that great. That's my mistake. The trick is using the C and the E grip. Okay. So I'm going to form a C grip over the mouth, an E grip over the jaw. And I'm going to administer breath. So you can't really see a good visualization of the lungs inflating. I wish you could. But if we squeeze too hard, right, we can see the lungs moving, but we potentially can end up harming our patient. We're administering about, once this is hooked up to 500 milliliter or 15 liters per minute of O2, we're administering about 500 milliliters or so of tidal volume or like O2 to where we're getting adequate tidal volume that's necessary for our patient. So I think it's right around the range of like 500 for the tidal volume whenever we do this. Oh, there you go. That's pretty good breaths. You know what the issue is? I'm not pressing hard enough with my C grip. And if you can't, I don't know if you can visualize it or not. The lungs are inflating really well. So I'm not squeezing hard, right? I'm just doing my little baby breaths because that's all the lungs need. Be really careful if your patient has CPAP, they're more susceptible for it popping. You can see it good. I'd love to see that. Thank you, Wolf. Let me read some of these comments. Why do they pay EMTs and paramedics minimum wage? Because we don't complain enough. But it's okay because we love helping people. So they take advantage of that. That's okay. That's part of it, I guess. Let's see. Definitely don't squeeze that whole bag. Yes, please don't. You can potentially burst a lung. How many charges can an AED deliver till it's out of battery? It should be enough for a whole CPR call. Don't worry about it. But if it does say to change it, you should consider changing it. Also depends on the patient. Pediatric patients, yeah, you'll have a smaller BVM. So if I had a pediatric patient, I'd have a BVM like this. And if you want to visualize the difference, we have an adult BVM, pediatric BVM. Very different in size. I'm still going to squeeze it. Oh, still going to squeeze it the exact same way. I'm just doing these three fingers. That should squeeze the bag about a third of the way or so, right? And that's what we want to see whenever we're administering breaths for a patient. Let's see. Also depends on, of course, thanks. We can see good. Do you have private online lessons? This is your lesson right now. So ask any questions. I'll have a test bank up in about 2 weeks or so. So stay tuned for that. How do you feel about accelerated paramedic programs? I think they're a great idea. Usually, accelerated programs are about a year long or so. I think that if you're focusing hard and studying hard, you can get the knowledge that you need to be a competent medic. You just need to push yourself. I did an accelerated paramedic program, and then afterwards, because of COVID, it ended up being a full length one. Actually, it was a bit longer. But I loved every step, and I just threw myself in my studies. So if you do that, I think you're going to do great. I would highly recommend it. Any new updates on the NREMT exam? Or are you making a new video anytime soon? I'm working on a test bank. I have carpal tunnel from it, but it's coming. I promise. Give me about 2 more weeks, and I'll have the perfect thing. I don't want to spoil it because there's going to be a video on it. You'll see it in a couple weeks, and I have tailored it, and I think it's a fairly cheap program. I had to create this website, do all these things. It's going to be beautiful. You guys will love it. Uh, I just finished my EMT program, waiting to get my code to take the NREMT. You're going to pass. Do the study guide video. The accelerated program here is 4 months. That's great. Okay, that's a little too fast. I thought it was 10 months. That's too fast. That's crazy. You're supposed to learn your stuff in that time. Are PEEP valves important for BBMs? Not really. I mean, just use the standard setup and you should be fine for patients. You should be able to administer 500 mLs. No big deal, at least for on the box. 4 months is crazy. Anyway, let's go ahead and get back to our code, right? So let's say we just delivered a shock to our patient, right? Then what's next? Okay. We perform CPR. We I did my compressions right. We charge. We all stood clear. I'm about like, let's say I'm 20 compressions in. Okay. And then we administer a shock. What do I do first? I'm going to ask the audience. Do I check for a pulse? Do I start compressions? Do I give the patient breaths? Because I've done 20 compressions, I haven't given breaths in a while. What do I do? What would you guys think I do? There's no wrong answers here. What would you do in this kind of call? Would you be like, oh, I did 20 compressions. We're on like 21 right now. Do I do those last 10 compressions? Do I start over? Do I bag the patient? What would you do? And feel free to throw out a guess because I will tell you the answer afterwards, or at least the appropriate one. Okay, check a pulse. Okay, so Clark says check a pulse. Is anyone out? Brave Clark. I'm going to plus two you for being brave, Clark. Anybody else? Any other possible guesses? Anything? Check out American Academy EMT. I just finished my 6-week program. Hopefully that's just an EMT. Okay, so now you're saying pulse check or back to compressions depending on your algorithm. Well, we have a cardiac arrest patient. We just administered a shock, so we're just doing a CPR call. So, do we assess a pulse? Do we start compressions? Do we breathe for our patient? I'll tell you the answer. So, the correct answer for this kind of thing, and thank you guys for being brave and giving your guesses, is start back on compressions. Now you may say, Mario, I did 20 compressions. Do I do my last 10 compressions and then do I bag my patient? No, you restart on your compressions. Okay. We're doing 30 compressions. Okay? So we're going to start back up. 30 compressions. Why? Because all we're trying to do is fill back up the heart. Then after I do 30 compressions, I know it's been a while. I know it hurts to wait. We're going to do 2 breaths. Now, I know what you're thinking. Mario, then when do I check for a pulse? Okay. Nobody really talks about that when they talk about CPR. When the heck do I check for a pulse? Because I just did 30 compressions after shocking somebody. I just gave 2 breaths. When do we check for a pulse on a cardiac arrest call? Well, my best recommendation for you, whoever's breathing for your patient, and you administer 2 breaths, maybe visualize them. Maybe see, hey, maybe I think they're kind of breathing on their own a little bit. Or hey, whenever I breathe for them, I kind of noticed I felt a little bit of pushback and I checked for vomit, of course, but maybe they're getting some of their own breaths on their own. Right? Then hey, maybe we got a pulse back. At the same time, if you're not sure, you're not going to hurt them by doing CPR, okay? If you have a patient that you just brought back and then you start chest compressions, you're not going to hurt them, all right? The heart's already messed up, the ribs are already broken. You're good to keep going, okay? So, when do we do this? Whenever the AED in a minute and a half prompts you to analyze the rhythm. You can't touch the patient. You don't want to give a false reading. So, what do? I remember my A and my B. I go down, I listen for breath sounds. I look at the patient's chest rising. I'm like, hey guys, I think the chest is rising on its own. I think I might hear pulse breath sounds. Uh, we might have had a pulse back here. And then the AED says, shock, not advised. Okay, time out for a moment. Let's feel for, it'll say continue CPR. Let's feel for a pulse. And then we feel it. And then we're like, I think I have like a slight pulse. And if you're like me, I kind of stink at this. I'm like leaning down. I'm listening for breath sounds. I'm looking for chest rise. And then I'm like, I think we got a pulse back. I think we got a ROSC. What do we do next, guys? Think about it. I'm going to read the comments. We just potentially got a pulse back on our patient. What do we need to do next? That's your question, guys. And I'm going to answer it. Let me read this. Check pulse, check out program compression. Back on compressions. Nice one. Santi. For the NREMT test, should I follow my book's protocols? Yes, you should. That's a great idea. You can also ask me any questions right now and I'll help you. I think the shock just changes the currency, but you need to pump the heart to get it, something like that. After you check for a pulse and feel for it, the next is to take a BP. That's my man. That's my man right there. Round of applause for Santi. Good job, buddy. You're right. We need to reassess our pulse. I'm sorry. We need to check vital signs. Let's get our vital signs going. What are our 6 vital signs? I'm going to look at my EMT partner. I haven't really been studying. It's my first day. What do we do now? What's our vital signs? And then you come in. Santi comes in and he says, he floats in, right? People are pulling him in. We check a blood pressure. We check a heart rate. Those are our 2 hearts. I like to do them in the same range every time. We check a blood pressure. We check a heart rate. Okay? We check an SpO2. We check a respiratory rate. That's my breathing. What do I check next? I check a temperature and I check a blood sugar, or I like to put FSBG, a finger stick blood glucose. Monitor it however you want. Right. So we got those initial vital signs. And you've done a great job. You brought the patient back. Hooray! Good job. Good job, everybody. We just got a pulse back. Fantastic. Betty Boop has given us a wave. Hello, Betty Boop. The beefy boop. Ew, beefy boop. I saw the video of your body cam on this video of a body cam on a whole cardiac arrest. Great idea. That's a great idea. Getting extra information. So I saw them, but never heard of that in school. Recommend it. I saw it too. It's a great video with great communication. We love communication. We're all working as a team. So we got to work together. Now, we're going to bring this from EMT-B. Now, here comes Mario. He just stepped up on scene. I'm stepping in as a paramedic. Okay. Now, what is some? I'm going to briefly touch up on this, but if you guys want to learn more about paramedic stuff or if you have other EMS questions, let me know. I can go way into depth on this. Okay. Some of the basic algorithms that we want to consider, right? Let's say they still have a cardiac arrest. The baseline that I want to do is I want to administer epinephrine every 3 to 5 minutes. What does that look like? I don't have it. We have imaginary epinephrine where we could push it into an IVIO. We're going to push that every 3 to 5 minutes. What else am I going to consider administering? If they've been down for an unknown downtime, I might consider administering next sodium bicarbonate. Right? Because the patient's built up a lot of acid, and I want to buffer out that acid. So I want to administer them some sodium bicarb, and then afterwards, I want to maybe say, hey, what kind of rhythm are we looking at, right? So my AD pads, I maybe took it off them and put it onto my monitor. So now I'm looking at the rhythm, and I said, hey, you know what? He's got VFib or he's got VTAC without a pulse, right? So of course we administer our shocks, do things like that. But is there any paramedics in here? Any ALS? Still in school, by the way? Don't worry about it. Great communication. Thank you. That's for that video. Any paramedics know what to do if you have a patient that's in VFib or VTAC without a pulse? Here, here. Okay. Yeah, it starts with an A or it could be an L. There we go. Mr. Mailman, good job. Fantastic. I talked to the firefighter who's done his NRH 4 times. He told me he's never been asked about CPAP or nasal cannula. Learn about nasal cannula, CPAP, you're okay for the EMT-B. I don't really need to know, but I'll talk about it later, okay? Just because you brought it up, just for you. He's right, though. What do I need to do? I need to administer my epinephrine. I need to administer sodium bicarb. And then, if they're in a shockable rhythm like VFib, VTAC without a pulse, hey, maybe I need to administer lidocaine. And maybe I need to administer amiodarone, depending on which one I carry. If I'm administering amiodarone, the standard dose is 300 milligrams. Wait about, I believe it's about 10 minutes. We don't carry amiodarone. And then we'll administer the other 150 milligrams easy. But that's only if they're in VTAC the whole time. For Anvil's protocols, we're administering lidocaine instead. We do 1.5 milligram per kilogram. And then we follow it up in about 5 to 10 minutes at 0.75 milligram per kilogram. And again, at 0.75 milligram per kilogram. And what's really interesting, let's say he gets a pulse back. My job's not done yet. I need to, if I have a Ross patient, I need to hook up lidocaine, a drip set, and I need to administer 1 to 4 milligrams of lidocaine and then titrate it accordingly because I want to maintain them having their appropriate rhythm. afterwards, and then I'll look, they have a sinus rhythm, fantastic. We got a pulse back. What am I considering doing on any cardiac arrest? Of course, I'm also hooking up fluids. I'm administering saline if I have lactated ringers. I'm hooking up lactated ringers. We don't have that. We have normal saline. That's fine. What can I do next? Well, after I get ROSC, hey, maybe we can disconnect this normal saline and we can get our cold saline that we have in our little freezer area or our kind of like our cold box. We can hook that up. We can administer some cold saline, try to preserve the body, preserve the heart as we head to the hospital and keep that ROSC, right? Maybe I've administered 2,000 milliliters of fluid or 500 milliliters of fluid and I hear something in their lung sounds and I can't maintain their blood pressure, maybe I need to set up a norepinephrine drip or Levophed, right? And then if that's the case, I need to administer it from 8 to 12 micrograms per minute. Right? We already have our bag already preset. It's really nice. All I have to do, we use the clock method. So 8 micrograms per minute is 30 drops. 12 micrograms per minute, I'm administering 45 drops a second or a minute. So fairly easy. Uh, let's see. For anatomy, should I learn muscle names? No, that's a waste of time. No, honestly, it's kind of a waste. It's not a bad idea to consider that. Let me check. It's not a bad idea to consider that, but really, you don't really need to know the muscle names too much. You might be wasting some more space that you could be honing in on your baseline. Like, let's learn our foundation. Let's learn our vital signs. Let's learn uh, our airway treatment devices. Let's learn about our medications, and then let's go from there. Right? It doesn't hurt to know about some of the musculature, but it's not really going to change too much, as far as I know, for your national registry. So I personally wouldn't focus too hard on the anatomy. I think it's great that you know it, but it's not necessary. Is my phone about to fall? No, 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 no. Let's fix that. Okay. So just some things to consider. Let's talk about one of our things that we can administer as an EMT-B. What's the highest blood glucose you've ever seen on a patient? It can read all the way up to high on a patient. And I've seen that multiple times. By the way, this is a training epinephrine. There is no needle in here. It's a training device. Okay. Do not do this for a regular EpiPen. You don't know if it's a train, or if you don't know if it's a training device or not. If your instructor hasn't said so, there may be a live needle, and this is considered a sharp. So be really careful. Uh, so again, high is the highest I'll read for a blood sugar. Not a big deal. I really like the glare that's right there. Um, but something like that, I mean, we're going to go to the hospital. We're going to give them saline, but we don't carry insulin. So there's not much that we can do for them, right? We just need to try to support them, watch out for my ABCs, and then administer saline, try to get that fluid going because maybe it's disrupting his brain or something along those lines. He could be going through diabetic ketoacidosis. Uh, and you could tell from the Kuzma respirations where they have deep breaths and rapid. So it's like those are Kuzma respirations. Maybe not as fast, but like, why are they doing that? Because with all the excess sugar, they're building up all this lactic acid and this they're trying to regulate their pH. And so how can they offload their pH? Well, they can release carbon dioxide by exhaling to regulate their blood levels or their pH balance of their blood uh, by doing Kuzma respirations. So I hope that answers something. Let's see. I start my EMT or my program in the fall, but I've always enjoyed videos about EMS and fire. What can I expect? Are there things you wish you knew when you took the class, or any words of wisdoms? All right, just have fun. It's a fun subject and it's very applicable. And I always find EMS to be so fun. I love it. I love teaching it. I love going over it. I love reviewing it. And if you have classmates, don't be strangers. You're all going through the same program. And I guarantee you, your program does not, it shouldn't be at least based off of like, well, he made 100, you made a 60 or a 70. So there's no curve because he got the highest grade. I've never heard of that for a paramedic program. You guys should be working as a team. You all go in, you all go out, you all work together, exchange numbers, make friends because you're going to be working with them all throughout your life. So jump in it, have fun, shake hands, get phone numbers because they may be your coworkers. They may recommend you for a job opening. Like I pulled almost like 80. probably like 60% of my paramedic class into Annabelle after we all graduated. It was a lot of fun. And I love working with all of them. Someone mentioned Carlo. I think it was Robert. I loved working with Carlo. He used to be my partner. So let's go over some EMT-B drugs. So right here, this is a training device, by the way. This is an EpiPen. This is an EpiPen auto injector. Okay. So for an EpiPen, we're able to administer this. When are we able to administer this medication as an EMT-B? Does anybody know? Let's see. Have you ever worked with Genius paramedics? Yes, I have. I've worked with Genius EMT-Bs. A Genius AEMT is Cool Breeze. I work with him a lot, and he's a little sweetheart. But anyway, um, yeah, I work with a lot of smart and intelligent people. You'd be surprised in the EMS field. And when people talk about like EKG rhythms or things like that, like they're on top of it. Anaphylaxis. Great job. It's a distributive shock. It is anaphylaxis. Remember, anaphylaxis is distributive shock. A lot of students have issues with that. It's because of all the histamines going throughout the body. That's why you would consider it distributive because it's a systemic. It's happening all over the body. Anyway, we have an anaphylactic patient. For the National Registry, they're going to ask you a certain question. They're going to say you have hives, but it's going to be a medical question of hives. It's going to be urticaria. Oh, hey, hold on a second. Hey, thanks for helping me pass. You're awesome. That's really sweet of you. I can even heart it. Oh, thank you so much, man. I really appreciate that. That's real sweet. Uh, thanks. All that helps with the channel. It's really nice of you. I should say your name right. Final Fantasy Chick 88. Thanks so much. Okay, what is the medical term for somebody presenting with hives, though? What is that called? Does anyone know? Anyone know what it's called? Anyone knows what it starts with? Anything like that? Dang, Mr. Melman, that's a good paramedic right there. There we go. Urticaria. I don't know how you pronounce it, but you got to know how to read it, especially for the National Registry. My patient is presenting with urticaria. They have shortness of breath. They have diaphoresis. What does that mean? They're just sweaty, like me right now, because the AC is not working here. So what do I need to consider? Well, especially if I see like swelling on the face, on the neck, on the chest, if I see any obvious facial swelling, like angioedema is what facial swelling is called. And you know what I need to do? Maybe I need to consider using an EpiPen and administering them medication. So what I'm going to do, I'm going to take off the safety lock like so. I'm going to go up to the patient's side. We'll use this dummy right here, and we're gonna actually. I'll just do myself. It's not a real EpiPen, okay? Don't do this if you're worried if it's a real EpiPen or not. Okay, talk to your instructor. Okay, I'm gonna go on the side of the thigh, and I'm gonna administer it like so, and I'm gonna wait 10 seconds. Okay, and I'm pressing at a pretty decent strength right now. And don't worry about clothes. It should be able to pierce clothes, but if you can move them out of the way, that's a great idea. So, 10 seconds later, we've administered our epinephrine. And what's the dose for an adult patient? It should be zero point 0.3 milligrams intramuscularly. Okay. That's the standard dose for an auto injector. If you can see, this is a training prop. Again, I'll keep saying it over and over again. We retract it. This is how it would normally look. You see how it shortens. When you administered it, it should cover the needle. However, what is this, everyone? This is a sharps. Where does it go in the sharps container? Be really careful. You don't want to accidentally stick yourself and get some of that medication in you, and at the same time, potentially risk yourself to exposures. It's a very unlikely chance of that happening, but if it does, contact your supervisor. This is a sharp. We're going to put it in our imaginary sharps container, or at least keep it to the side where we know where it's at. Be really careful for that. Now we're going to wait about 3 to 5 minutes. If we want to, set up a pulse ox on our patient, check out their breathing, see how they're doing. And if I need to, maybe I'll administer an auto breather, a nasal cannula. But most of the time, this kicks in like a minute or two. It is an amazing drug. You're going to see the highs start to dissipate, the shortness of breath as the bronchioles are starting to relax because they're not constricting as much. And they're going to be able to start taking deep breaths. They're going to start being able to breathe well. Let me read this. Let's see. I was thinking about entering T practice. You said vasodilator. This acts as a vasoconstrictor, but anaphylaxis will cause vasodilation. So this kind of brings back everything. Uh, I was taking an NRT test question and someone had a broken lower leg in a motor vehicle accident. I selected the first thing to do was C-spine, but it said no, rapid assessment of trauma. Not the best question, right? I would have considered C-spine precautions along with like ABCs, things like that, and then work my way down and then assess them. But it is what it is. I like doing C-spine precautions. I think that that's a really good idea, at least to start off. Okay, but it's okay. They probably have their good explanation for it. There's multiple ways we can skin this cat, right? So, dang, I got the live delayed. Sorry about that. Reading a chapter at the moment about cardiology monitoring for EMT. What would that be on the registry? You will need to know. No, no, just know that sometimes the monitor won't shock, and that's just a not shockable rhythm. Don't worry about interpreting an EKG. That's for the workplace, not for EMT-Bs. Paramedics, you better know all of them. Let's see. Blue to the sky, orange to the thigh. That's a great interpretation. Orange to the thigh. That's where it's going for an epi auto injector. I like that. It's slick. Always remember from school. Okay. Is there a difference between bronchospasm and inflammation of the bronchi? So you're talking about like a laryngospasm. Uh, that can occur from like some like asthmatic patient. There's a couple other ways to do it. I've actually heard of like a laryngeal massage, although I'm not too familiar with it. Honestly, just administering airway medication. If you hear like wheezing, give them albuterol. Just treat the patient, try to calm them down, and hopefully that'll kind of help it pass. I don't have much good information past that. Uh, Inflammation of the bronchi, though, that could be a couple of things, right? We could maybe have like a COPD patient and they're having some inflammation of the bronchi, like excessive mucus production. And then that would just come from like the patient history, things like that. But besides that, I mean, we can have maybe inflammation of the smooth muscles, and then that could be more so regarded to like, oh, is this an airway issue? Are we thinking anaphylaxis? Are we thinking maybe they're having an asthma attack? But inflammation of the bronchi, we would think more so like COPD or chronic obstructive pulmonary disease, and that can either dive into like COPD, like it could be chronic bronchitis, or it could be thank you, emphysema, and so it's either emphysema or chronic bronchitis. Let's see, from allergies. It was okay. I only have 1 semester worth of GI Bill remaining, so I'll probably take the ridiculously accelerated paramedic program. That's a great idea. It's made in your best interest in then, and I would highly recommend doing that. I think that's a great idea. I think you're on track for success. Uh, would you recommend studying anything this summer to prepare? No, you can watch some of my videos for fun. You can watch other people's videos for fun. But honestly, just do what your program says and go in ready to learn and go in ready to have fun. Good to have a little bit of preparatory knowledge, but you could be wasting your time and you could be losing some of that effort. Just enjoy your family time and have fun. And whenever paramedic school starts, or yeah, EMT paramedic school, whichever one you're doing, you said paramedic. Uh, Run with it. You know, don't worry about this whole preparatory thing. It's not necessary at all for EMS. You'll just follow the program, pass the national registry, or message me and I'll help you pass. Okay, I try my best. Anatomy and physiology doesn't hurt for anatomy and physiology to study up on it if you want, but watch like a fun video. Don't spend hours learning it. It's great to know it, but you'd be surprised. Like you really need to know your anatomy to a good extent, but the program will teach you that. Okay. So don't worry too much about it. Maybe just work and just have fun with family because you're going to say goodbye to them in that accelerated one for a while. What is the bread and butter baseline information every EMT and paramedic should know? I'm about to branch off into that, but I need to talk about CPAP because someone talked about CPAP earlier too. Does National ever ask statistical questions such as what is the number one cause of death, stroke, shock, etc.? They may. I doubt it. That's not really something worth learning, honestly. I wouldn't worry about it. Statistics are nice. Just know more so about the Department of Transportation, the National Institute of Safety Highway something, NIOSH or something. Maybe know about that. It's not a big deal, honestly. Okay. What should every EMT and paramedic know? That's a great question. I'm so glad you asked that. What I know, Well, first, know my baseline vitals. So I always talk about in my videos that you should know 6 baseline vitals, but there's a seventh one for paramedics that I'm going to talk about whenever it's time to go over my paramedic review. I hope my gulp isn't weird. What is that seventh vital sign that you need to know about? It's a numeric thing. So just think about it for a second. Oh, I love Bang so much. They're so good. So, capnography. He's on it. That's a medic, right? Oh, look, Santa's got it too. ETCO2, good job, good job. GCS, that's more so like your assessment, but I'm thinking vital signs. That's a great answer, though. That's a great answer. And you said, does National ever ask? Oh, I already answered that. NIT soon. What's the best dusting tools? My study guide video, honestly, is fairly comprehensive, and I think you'll do good with it. Anyway, ETCO2, end tidal capnography, or end tidal carbon dioxide. We'll just call it end tidal capnography. It's a great device. You can either hook it up onto nasal cannula, or if you're working in cardiac arrest, I don't have a good visualization. Maybe I do. Oh no. I have a colorimetric device here, but it's a shame I do not have end-tidal capnography. Anyway, if I have a BVM set up, what can I do with end-tidal capnography? What I can do is I can pop this little thing right here. I can hook it up in between the two, and I can start breathing for my patient again. And I'll swap right here to do the C and E grip, and I start bagging for my patient, right? And of course, I'll go at the correct rate. And then what does end-tidal capnography measure? It measures their CO2 production, right? So normally we exhale CO2 or carbon dioxide, right? It's a normal byproduct whenever we have our respiratory system intact. So we're inspiring oxygen, we're expiring CO2. The normal range is going to be between 35 and 45. I think it's millimeters per mercury. I think that's the unit for it. But just know 35 to 45, that's normal. If we have a cardiac arrest patient, what do we expect their ETCO2 or what do we expect their carbon dioxide to be like? Do we think that they have a lot of carbon dioxide or do we think they have a little bit of carbon dioxide coming out? What do you guys think? Can I get hours for this? Man, I wish I could do hours for this. I can't. Obviously, I can't change anything like that, but you can talk to your instructor. It's not a bad idea. Uh, WH tappings. Okay, so you got a number out, 15. So what do we think about 15? Is that a low amount of carbon dioxide or is that a high amount of carbon dioxide? Right. So let me see here. Da-da-da-da-da-da-da. We're just going to kind of move with it. So we're expecting them to have a low amount of carbon dioxide production. Why is that the case? Because their lungs aren't working on their own. Right. So what we would expect is normally 35 to 45 units for their capnography as we're measuring it. And then it may start to lower a little bit. And now we've got uh, 15 to 25 units or 25 to 35 units for the capnography. Okay, their lungs aren't working properly. They have this built up CO2. And maybe we're working a cardiac arrest and let's say we have capnography set up because we did a really good job and we're doing compressions and we see that the reading's at a 10. You know what we need to do then? We need to look at our compressor. We need to say, hey, are they doing adequate compressions? Are they pushing in hard enough? Are they pulling back hard enough? Are they doing the proper recoil? Maybe they're getting tired. Maybe I messed up and they've been on CPR for 6 minutes, 8 minutes. When we see a low ETCO2 and they've only been down for like 5, 10 minutes or so, we need to swap out our compressor. Okay, they're having some trouble. Be kind to them, but swap them out. That's usually the issue. Also, just check the setup as well. But swap the compressor. Okay. Now, let's say later on, 15, 20 minutes in, we're getting readings at like 15 or so. I mean, the body can't really produce much else. It's already having trouble as is. That's a fairly normal reading at that time. We still don't want to see 10 if we can help it, but sometimes it is what it is, and it's not the compressor's fault. Uh, we just have to see how long a patient's been down. But we're doing cardiac arrest. We just administer a shock. We're going through our cycle, and now we see a spike of ETCO2, and their ETCO2 is now at 55. or it's at 65. What are we thinking? What are we thinking if we have a patient whose end-tidal carbon dioxide is now up instead of down? We're thinking of ROSC. We're thinking of return of spontaneous circulation. We're thinking we got a pulse back, right? And what's happening? The patient's breathing on their own. And now they're taking all that excess of CO2 because they got a lot built up and they're exhaling all of it at the same time because now their alveoli are into play, right? So then that's another confirmation. Now instead of you being like me and being like, do we have a pulse back? I think I see breath sounds. Hey, we got an ETCO CO2 at 55. Let's hold off for a moment. Let's take a look at the monitor. Let's do a pulse check. And whenever I'm doing a pulse check, I like to check one side. If I have multiple medics with me, or if I have multiple partners with me, it doesn't matter who. I'll say, hey, can you grab the radius and the carotid artery? Can you, or the radial artery, carotid artery? Can you get a feel for it too? Can we get multiple eye or multiple people feeling for a pulse? Because sometimes I just miss it, right? If my partner feels it, fantastic. Hey, we got a pulse back, and I'm glad that you're checking it. But let's get involved. If somebody's not assessing on the neck, somebody's not assessing on the radial artery, even if you're brand new and you're working in code, get your hands in there, right? Because that's the best way to learn. And maybe they feel something, and you're like, you know what? I think I feel something too on your side. Now you have that muscle memory and that moment where you're like, hey, I know what it feels like, and you can do it by yourself. So always try to get in there. But we got a pulse back. That's why we're seeing that high elevated ETCO2, and it's just slowly start to regulate to 35, 45 over time. Make a video and illustration like a tree that leads from one emergency to another. Because I have trouble understanding CHF, cardio shock, AMI, hypertension. We'll talk about all that right now. Oh, that's great. Actually, that's how I think about EMS, right? Is I have like a box, my patient, and then they say I have chest pain, and then I in my head there's a line, and then I'm thinking, okay, what is it? Like they have chest pain, like is it from breathing? Is it from a cardiac issue? Is it from like a psychiatric issue? Are we thinking something as simple as GERD? What's going on, right? And then I'll do my vital signs, I'll do my checks, I'll assess their pain level, what's been going on, what happened beforehand, right? Did they just have an argument? Or were they working outside in the sun and they sat down and now they have chest pain and they have 3 stents? There's a lot of information we can gather. So trying to get myself in the angle here. It's because it keeps tilted. A little tricky. Anyway, let me read this. Uh, Elaborate on the ABCs. I mean that it's the most basic thing. If all else fails, go back to your baby ABC. He's completely right. So you asked earlier about what should every EMT-B and paramedic know, or AEMT? Well, they should know your basic vitals. That's really sweet of you. I just read that. Thank you. Thank you, Nick. That's sweet of you. Okay. Know your basic vitals. Know your airway tools. Know your medications. If you're a paramedic, know your ETCO2 value also in your vitals. Know all of your medications. Know your rhythms. Okay. And then from there, it's really just niche information. Those are your basics, right? Kind of know where you're at on a call, by the way, too. If you're taking a national registry question and we're inside the back of the box, and it's going to say, what do you want to do next? Do you want to perform a secondary assessment? Do you want to start an IV? Do you want to administer Zofran? Or, which is a nausea medication, it's for AEMTs and paramedics only, not EMTBs. Or maybe do you want to check for scene safety? And I don't know what's going on with the rest of the questions, but I want you to take a step back. Hold on. I got my patient. I took him in on the stretcher. I did all my things. I brought him into the medic unit. I have him all set up. I'm working on all these things, considering all these things. I have him in my box. If I check for scene safety there, you're basically saying, did you check for? It's good to reassess, but you should have already done that by now. And so that answer choice would be wrong. It's common sense. Of course, you're like, oh, I need to check for routine safety every time. But if you answer that when you have a patient already in the back of the box, you're technically wrong because that should have already been done by now. So watch out for that. National Registry will get you on that. Uh, let's see. I hope that answers some of your questions. So if I can reiterate it one more time, know your basic vital signs, know your medications, know your airway equipment, and know if you're a paramedic or AEMT, know your EKG rhythms. Okay. From there, it's all fair game. I had to study up more on OB because I struggled with it. Let's see here. I feel H's and T's are things that people forget about. They are. And we can talk about, I only have some of them off the top of my dome, right? Because it's something that I check, but I don't really say. And that's kind of, it's on me as well. So what do we have? Like we have our hypovolemia, we have our hypokalemia. What? So like hypovolemia, low blood volume, hypokalemia. If you're a paramedic, you're thinking, okay, like electrical rhythm imbalance, like a potassium. Maybe they have too low potassium. Hyperkalemia, they have too much potassium. Uh, what are they eating? Bananas or I don't know. It's, I mean, it's okay. It's whatever. Anyway, maybe we're thinking of hypothermia. Maybe we're thinking of thank you, hydrogen ion acidosis. That's a good one. I would not have said that. Maybe we're thinking of hyperglycemia, hypoglycemia. Maybe that's something that's going on. All that we have to think about stuff like that is like, yeah, we can say H's and T's. What does that really mean? Hey guys, we have a cardiac arrest patient. We've been going on for about 10 minutes. Has anyone checked a blood sugar yet? Golly, could you imagine if we were have a cardiac arrest patient, you're going on 15 minutes, you show up to the hospital, and they're like, "Did you check a blood sugar?" You say no. All the nurses and physicians look at you like this. They're like, "What?" They check a blood glucose, and their blood glucose says low or at a 30, and you're like a paramedic. You're in trouble. You're in trouble. You need to make sure you check that and you get that situated for like 5, 10 minutes before you get to the hospital. That's a good way to get into a lot of trouble. Check your vital signs. Hey, you know what? H's and T's, hypo or hyperthermia. That's it. All falls back to let's check a temperature. Check a temperature. Hey, he's at 95.5. We need to throw a blanket on this guy while we're working on everything else, right? And we need to go from there. Maybe sometimes some protocols will say, hey, deliver a shock on a patient. Like, let's say you're a medic, but you have a patient who's at like 90 degrees Fahrenheit. But until you can actively rewarm them, you can't administer a second shock. And I highly recommend you look at your protocol. Some will advise not to shock the patient, even if it's time to after you've done it the first time. If you have a extremely hypothermic patient, like this is severe hypothermia, I'm thinking like 90 degrees Fahrenheit and below, things like that. So maybe we need to get some hot packs. Put them around the neck. Put them around the joint, the axilla, the armpits, right? Put them around the groin. Put a blanket on them. Try to have some active rewarming techniques. Watch out for that. Maybe turn off the AC, even though everyone hates it, because we need to warm up our patient. So use hot packs. Good thinking. Good thinking, WH. All right. I appreciate your channel. Thank you. Megan, I appreciate you. Thank you. Uh, anybody know the days? Remember the days of jumping Dougs down the ET tube? Yeah, we don't push medications down the ET tube. Now, your protocols may be different. My paramedic instructor told me again and again, we don't push medications down the ET tube. We don't do that no more. Are you a theoretical plasma fusion physicist? I don't know what that is either. Just take it as a compliment, I guess. Charge nurse gonna be, yeah, they're gonna throw a fit if you don't check a blood glucose or a temperature. I mean, guys, that's basic vital signs. Sometimes we get too excited. We want to do all these things. Got to take a step back. We have an extra set of hands. Ask him, hey, can you give me some basic vital signs? Also, listen to your partners. Maybe you're struggling a little bit, but your partner's like, hey, have we checked your blood glucose? Don't get mad at them. Be like, thanks for bringing that up. You're right. Let's go ahead and check it. Hey, we're working in cardiac arrest and we're a paramedic or an AEMT or even an EMT-B, and we've worked on it for 10 minutes, it's hot outside, or even if it's not, you know, maybe they're going through hypovolemia. Why not hang up a bag? Even if it's saline, let's set up a saline bag. Just leave it open. Maybe that's what we need to do for our patient to fill up the heart to get it to start working again. Let's see here. UC packs 2 under the patients on the okay. The ET2 was way back in the day. Do you transport cardiac arrest patients? I do, but I also like to set them up on scene. I have worked cardiac arrest patients multiple times on scene, and it's due to my discretion as a paramedic. I think as an EMTB, you always need to transport a patient because you can't call it in the field. I can call it in the field if I work it for 20 minutes and I find it unsuitable. Let's say if I'm far away from the hospital, or if I just don't think that it's appropriate at the time. I'll do whatever is best for my patient, but it's very, very wishy-washy. You'll never get in trouble for transporting a patient to the hospital. You may get in trouble for not transporting a patient to the hospital. So I'll leave it at that. Uh, anyway, somebody way, way back then asked about CPAP, and I'm so sorry we got lost in the sauce and we did not talk about CPAP for you. I'm so sorry about that. I don't have it here with me, but you know what I do have? I've got a whiteboard right here. And with my whiteboard, I bought some dry erase markers for this occasion, which I will gladly pull out. A lot of people struggle with CPAP, but it's very simple once you take a look at it. It's going to take me a moment. While I'm setting this up, huge shout out to Annabelle Fire Department because I'm in their complex right now and they're very nice to me and they're very sweet to me. Two things before we talk about CPAP, or three things. First off, what is CPAP used for? Does anyone know? You should get buff. I am I'm working on it. Oh, he's talking about something else. Whatever. Anyway, uh, so we have I don't have CPAP equipment, otherwise I would. I did not bring it. I'd love to go over it, but we'll talk about everything else CPAP, okay? So what is CPAP used for? I think somebody brought that up. I don't know if it was in Discord or in the comments or if you brought it up, but you said asthma exacerbation of CHF, fluid in the lungs. It's in the name. Continuous positive airway pressure. That's kind of a little iffy if it's really in the name, but it is used for that pulmonary edema. Keep the alveoli open and create more space to diffuse CPAPC. Sure. Drowning patients. Okay. All excellent answer choices in their own ways. So, in my personal opinion, when do I consider using CPAP? I consider using for a patient who has fluid in their lungs. But that's not it. They need to be in respiratory distress. Okay. So I'm expecting an SpO2 lower than what? Lower than 94%. Okay. Maybe their respiratory rate will be a little elevated. Maybe it'll be at like 22. They're trying to get a breath in. Maybe it's at 8. Oh, no, can't be at 8. Maybe it's at 22. And we'll talk about why it can't be at 8. Um, so they're trying to breathe a little bit more. They're having trouble breathing. I've had where I've administered COPD for a patient. Is a patient's like, I feel like I'm drowning. I feel like I'm drowning. We're setting up the CPAP while we're getting their pulse ox at the same time. So we're not denying oxygen administration, but we're assessing our room SpO2 before we administer it, and we're setting it up. Lo and behold, the patient's SpO2 is at like a 50 or something. They really couldn't breathe. But fluid in the lungs, but they can't have a fever because if they have a fever, what's going on? They could be having pneumonia, right? And we don't really want to push that throughout the whole body. Now we can still consider uh, CPAP if it's really obstructing their breathing, and they can administer medications at the hospital, like antibiotics. But for the most part, I want to leave them alone. Right, I'll give them a nasal cannula, non-breather, have at it. Right, but if it's pulmonary edema, fluid in the lungs, the SpO2, I'm gonna say like a range, probably like around 80 or so. Then I'm like, okay, it's probably CPAP time. But please go at your own discretion. At the same time, there are some big contraindications for CPAP. Does anyone know what it is? And I'm gonna read some comments while you guys think about it. What are some contraindications to CPAP? Because you can kill someone. Let's see. At 8, you need to be coached, and below, you need coached BVM. Let's say it depends on the patient's presentation, but that's interesting, Megan. How do you coach a patient during CPAP and why? Push the fluid in the back of the lymph. Okay, so don't CPAP septic patients. I wouldn't. I wouldn't. Unless I would more so put them on like a non-rebreather or something. But if I suspected if there's a lot of fluid in their lungs and like I know it's what's causing them to have trouble breathing and they're still ANO times 4, okay, maybe I'll consider CPAP still, but it's not a great idea. I'd rather not if I can just give them a non-rebreather and leave it at that. Okay, so it's hypotension. Also, it's an altered mental status. If they have an altered mental status, if they have hypotension, I am not administering CPAP on a patient. Okay. I'm also really wary for patients who may have like a past history of CPAP because we're potentially going to burst their lungs or the alveoli. Right. So I really don't want to damage my patient because it's a lot of pressure. Uh, if you have the extra supplies and let's say you have like 50 expired non-rebreathers at the station or 50 expired nasal cannulas or something, You're like, hey, we got to toss these all. These are all useless. You work at a department or agency. Say, you know what? Hey, real quick, with my supervisor, are you okay if I try one of these on real quick? It's just 8 liters per minute or 10 liters per minute for like a non breather, 6 liters per minute for a nasal cannula. It's a lot. It's a lot of oxygen. It's very uncomfortable. Anyway, if a patient is hypotensive and then you administer CPAP to a patient, you could potentially compress the vagal nerves, causing less blood return to the brain. You could cause them to vagal out, and you could potentially kill your patient. They have an altered mental status. They can't properly utilize the CPAP and breathe with it. You could potentially harm your patient. Better yet, just use a bag valve mask if they can't control their respiratory rate. Okay, that's whenever we consider like, hey, maybe we have to go mechanical ventilation for them instead of letting them do this device that would normally be used by itself, like a CPAP device. So they need to be ANO times 4. They need to have a normal blood pressure, and then please follow your protocols because it's a play by play depending on your protocols. Don't just listen to my advice and say that's it. Uh, Now there's a couple ranges. Let's see, contraindicated and high thoracic pressure. Uh, Possibly. Do you mean like for a contraindicated for a patient who has like, let's say, like you're talking about a pneumothorax or something? I mean, you wouldn't do it for a pneumothorax. You would, if you're request paramedics or request ALS intercept, and if you're a paramedic, what do you consider a needle decompression between the fourth and the fifth rib, or midclavicular second and third rib? Again, fourth to fifth if it's mid axilla or underneath the armpit. I think people like to use the four fingers under the armpit and then they go right around there. If you do use the rib, you ride over the rib. You don't go underneath the rib because the arteries and the veins are in the rib. Okay, so you go over the rib. Let me grab this. People struggle all the time with CPAP. What do they struggle on? Well, they struggle with the ranges, which is super easy once you get good at it. I'm going to flip this like so. So for CPAP, we have the different PEEP ranges. This will not look that great. And then for the PEEP, we have different O2 settings. We're like liters per minute, right? Boop, boop, boop. Okay. So please check your manufacturer, make sure it's the same. Gosh, that looks horrible. Make sure it looks the same as what I'm talking about. Know your equipment. Don't just trust this. This is just a general guideline for people. Age is reversed. Image is reversed. Oh, geez. Oh, geez. Okay. Just listen to my what I'm saying then. Okay. 5 PEEP. We have 5, 10, 15. It's so hard to write and then do this 20 and 25. Okay. It may seem really complicated, guys. I'm sorry if it's flipped or whatever. I don't have the technicals. I can't flip. I don't know what to do. Whatever. Anyway, my camera's slipping also. We'll just screenshot and flip. Great idea. Or we could just talk about it again. So 5 PEEP. You can write this down also. It's at 8 liters per minute. Okay. 10 PEEP. Or put a dash. 10 PEEP is at 12 liters per minute. And then, guys, it's the same thing across the board. 15 PEEP, 15 liters per minute. Oh, that looks so bad. I'm writing goofy, guys. I'm sorry. 20 PEEP, 20 liters per minute. 25 PEEP, 25 liters per minute. Looks better, right? Okay, so I'm going to leave this right here for a moment. I don't know. I don't have. Is that better? That does. That doesn't help. I don't know, guys. Like this, like this, right here, guys. Just figure out a way to flip it. 5 PEEP, you do 8 liters per minute. 10 PEEP, you do 12 liters per minute. 15 PEEP, you do 15 liters per minute. 20 PEEP, you do 20 liters per minute. That looks so bad. 25 PEEP, you do 25 liters per minute. It looks like sixes to me. Uh, but we also have a Discord. and it's in every single one of my YouTube video descriptions. Ask me questions, guys. This not only will I answer the questions, but I've got sweethearts in there. I've got people like Dan answers a lot of questions. I've got Full Breeze, easy, big LDP. He answers a lot. The Kaisi, the Yoda picture person says a lot. The first citizen person, they say a lot. And we'll answer your questions, guys. And I'm not the final answer. I'm not the final voice. There are a lot of talented EMS individuals, and they state their role in the role check or whatever. So you can right click any person in Discord and be like, oh, hey, they're an EMTB like me. Oh, they're an EMS student or they're a paramedic. Okay, it's optional if you wanna say your role or not, but, use them to kinda help with your knowledge. So, don't be afraid to ask. We are a community that's gonna work together and propel EMS education in general. That's the whole point, okay? So you gotta see my greasy face, guys. I'm sweating so hard. Is there a spot that I can hang this up at? This horrible drawing? There you go, guys. It's in here. Let me look at some comments. Theoretical plasma infusion physician is a scientist that tries to create mathematical frameworks. Ages reversed image. I'm not smart enough for that. I'm not either, by the way. Although I am a cellular and molecular. I have a bachelor's degree in cellular and molecular biology and a minor in chemistry. So I used to study mycology a lot. I had my own lab. Cool. Maybe I'll make a video on it one day. I used to sell mushrooms that are legal at a farmer's market at one point in my life. It's really fun that I grew. Anyway, I would just screenshot and flip, no biggie. That might be a good technique to learn. Really work to absorb it. I'll never forget now. Good, good. Remember how I had to do this weird flipping thing? And again, it's so simple, guys. I'm gonna have to do that again and again. Guys, CPAP is not hard to do, okay? The most unnerving thing for people is putting the straps on your patient, but we make things medic proof. We make things EMS proof. We make it very clear where things are going to go. It's going to have the same curvature in its base form. We're just like a BVM. We're gonna have a mask like this for a CPAP, right? Where does the nose go? Doesn't go here. The nose goes here. It's preformed for the nose. Back here, it's kind of where the jaw goes. Okay. So don't be concerned about that. And then you put the four straps. One, two, three, four. You're done. So that's CPAP in a nutshell. Any other questions? I remember somebody had an AMI question. Mario, what's my age? I'm going strong on 30. I know. I look like I'm 29. I know. People tell me all the time, but look, I'm a taken man. Uh, but I'm 30. Anyway, makes me miss the combi tube. It was a 50-50 shot. What he's describing there, a combi tube is a airway device that had two different little balloons. You put it in, you push air, and it fills it up, and it kind of blocks any fluid going from the esophagus. So a combi tube, maybe I can use this, right? If you want to visualize here, we have two tubes. We have the trachea and we have the esophagus here. Okay. And the trachea, well, if you're a paramedic, you'll have like your epiglottis. I think it's called a valliculus, like your epiglottis flap. I'm kind of messing up on my terms here. That's kind of embarrassing. I'll have to look more into it later, but luckily somebody will say it. It's not your epiglottic flap, is it? Why am I getting a little brain mess up here? Anyway, blah blah blah. You have your airway flap thing here. Somebody please say it in the comments. Uh, don't worry, I know what I'm doing. Okay. So you have your trachea and you have your esophagus. Okay, and what the combi tube would do is there would be two balloons. One would block the esophagus from any stomach contacts or any throw up or vomit from rushing out and going into the trachea to the lungs, where a patient would potentially aspirate or choke. Epiglottis. Thank you. Thank you very much. I don't know why I was tripping up on it so much. I was like, this is something else, blah, blah. It's the epiglottis little flap here. Okay. Thank you guys for that. And then the other one puts another balloon right here to kind of keep it in place. And then whenever we would breathe for our patient, it would allow air to somewhat get into the trachea. Now it's not perfect. I have another airway device that I wanted to show you guys today. Is it not here? And I have it right here. We don't use that anymore. I'm going to read this real quick, guys, and then I'm going to go back to it. Uh, let's see here. Mario, I have my EMT, NREMT coming up. My class ended last week, and I feel like I'm losing every bit of info. What do I recommend? I do. I watch your prep for NRMT. That's a great way to go about it. Okay. Uh, I would highly recommend just rewatching that video. I have people like 3 times a day, and they're so sweet, commenting saying, "Hey, I passed the national registry," and can't keep up with it. But it's a really effective tool. Message in the Discord any questions you have, and we'll definitely like to talk to you about it. Okay, glottis, we talked about it. Sorry about messing it up, guys. Is that like a Keen tube? Yes, it's kind of like a Keen tube, except there's two little balloons instead of one. Epiglottis leaflet. Why don't they? Let's see. Megan's. I think she said something important, right? Why don't they make connectors on rescue mask compatible with bags? Rescue mask. What do you mean by rescue mask? If you could specify more on that, like, connectors like a CPAP to a BBM, or what do you mean? I apologize, I don't know what you mean. Uh, let's see, pocket mask. Why don't the pocket okay, why does a pocket mask can somebody link the Discord, by the way? I can't mess with my stuff, but I would really appreciate it. Uh, I don't even know if you guys can post links. I can do it. Give me 20 seconds, guys, and we're going right back into it. Let's see, invite to channel. Can I just copy a link? Can I paste a link? There you go. There you go. Did I do it? I think I did. Okay, okay, yes. Okay, so pocket mask. Realistically, we're not going to utilize a pocket mask whenever it comes to long-term care for a patient, right? We're going to swap the pocket mask or like the little mask that we have. I believe that's what you're referring to for a rescue breast for a patient. We're just and EMS whenever they arrive, they're going to swap straight over to a bag valve mask. We're just going to utilize this. And what's great about this piece of equipment, we can make our C right here and use our E around the chin. So like so, we get a really good grasp on our patient. We're able to breathe for our patient too. Okay, so this is not the best mannequin for breathing, but that should work. Megan just landed. Okay, that means that the Discord link worked. Fantastic. I was so scared. I actually linked like a wrong Discord or something. Not like it would be bad. Sectioning is fun with the old jail over there. What's the difference between emergency department doctors and paramedics? They do a lot more than we do. They're extremely talented. They know how to manage their respective personnel and coworkers, and we bring them to the ER physicians, and the ER physicians hopefully can fix the problem sometimes, or sometimes we have to kind of keep them alive to fix the problem, and the ER physician will go from there. So there's a huge distinction between the two. They're extremely talented, and 99% of them are sweethearts. Every ER physician I pretty much talk to, as long as I don't make a mistake, which I've done before, and I have gotten ugly look here and there, but it's rare. They're always super sweet. They're really nice with EMS. So they're just great. Anyway, have I ever done a surgical? Let me read down here first. A Venturi mask? Not too familiar with the Venturi mask. iGel is not an Apple product. It's not, but it's the LMA or the iGel is beautiful, and we're gonna go over it in a moment. I just got to catch up here. Mario, have you ever done a crike on a call before? No, I haven't. But I used to work for Allegiance, and they had a crike kit, and I was like, "Hey, if I have to do it, I do not want to." The chances of me doing it are really limited. Let me give you guys a little patient story, super quick. I've had a patient where this was years ago, where it was a fire call, and I was a medic that showed up on scene, and this guy was fighting a fire with a garden hose. Right, he has asthma, and he's trying to protect his house. So he's in the backyard, making sure that the fire isn't getting to his house. And so he's breathing in all those superheated gases, right? He's also exerting himself, maybe an asthma attack too, kind of going on. It's like a mix. So I get him in my box. He's like, "Hey, I think I'm having an asthma attack. Can you give me some albuterol?" I say, "Sure, go ahead." Give him some albuterol, fix him up. He's like, "I don't want to go to the hospital." I was like, "I really think you should go to the hospital. I really think it's a good idea. Just because your past history, I didn't have any singed smoke or anything." And I was like, I really want you to go, but I can't force you. So I'm working on like getting a refusal on him. And then he's like, you know what? I'll go. So I'm really glad I pushed him to do it. We're setting him up. I set up an IV on him. And then I have a EMS student with me. And then I tell the EMS student, "Hey, big mistake on my part because it's my IV. I should have been set up." I was like, "Hey, hold on to this. I'm going to go and I'm going to get the saline lock and the flush." So I get the saline lock and the flush. I hear, "Uh oh." I turn around, my IV's out. My patient is like this, like going with audible gas, and you can hear him like, right? His airways closing quickly. The albuterol, it's done. It's not helping anymore. He has audible gas, and I'm in my head. I'm like, okay, I'm at Annabelle. I don't have surgical cryo protocols. I do have scalpel in my OP kit just in case I need to use it. I don't have RSI protocol, so I can't knock him out and establish an advanced airway. I know from everything that I've heard that's going on is that he inhaled superheated gas. He's having an asthma exacerbation. Both are compounding, and his bronchioles, the smooth muscles around him, are just constricting and closing his airway. What do I need to do? I got an albuterol mixed ready at 0.3 milligrams for an IM. Gave him the shot, fixed him immediately, and he went back to normal. Now, I don't recommend that. I recommend talking to medical control. But I was a paramedic at the time, and I talked to the physician afterwards, and he's like, "Oh, you did a good job." But very scary call. It can be very dangerous. Let's see here. So we're going to talk about the LMA now. This is expired, so I do not feel bad about opening this. Otherwise, I would not. The Yeah, super clutch. I uh, I was already teaching EMS a little bit at the time, so I that's a good reason to get the patho down because I was like, I kind of know what more or less is going on. I know what tools I have at my disposal. And if you're doing a cervical crike, what are you considering cutting between the cricothyroid membrane? So, like if I have my Adam's apple here, it'd probably be right about here. That would make a slit, and then some people do a cross, some people don't. And then you want to, I think some people like stick their finger in and then have the two ready to swap. It just kind of depends on how you want to go about it, or how you're taught. It's really tricky, and I don't have much experience on it. But that's for a last ditch airway that I'm not comfortable with doing. But again, if I talked to medical control and I had to, I would do it to save a patient's life. I don't want to by any means. Anyway, here is my LMA, my iGel, super cool piece of equipment. I'll open it up, and I will not drop it on the floor like I did because I want to stay sterile. All this stuff has got to get out of the way. Ah, so we're gonna move this dummy, this beautiful dummy, right over here. We're gonna move some of this stuff out of the way. This will be training equipment for later also, so I need to be very careful with. I'm gonna trim this like so. Hmm, maybe this is the best way to do it. Let's get a little close up, right? Can I do a close up? Hey, enhance. Enhance. Excellent. So I'm considering, hey, you know what? I can't get my ET tube in, or for whatever reason, my protocols are like, hey, just throw an LMA. Some instances or some agencies will let EMT basics administer an LMA or like an advanced EMT, depending on where you work at. So check out your protocols. It's a great piece of equipment. So I will pull out the LMA. It has a little protective case here. Pop it out like so. I will pull this off like so. And I have my little packaging here. And what do I have back here? I have some lubricant that I can utilize. I don't want to lubricate the dummy. I actually have a little spray right here. I'll use that. I don't want to mess with stuff that I'm not supposed to. There you go. Nice and lubed up, right? The LMA is what we call EMS proof or dummy proof. What I'm going to do is I would normally open this up. I'm going to lubricate the back. Use hand sanitizer? No. I'm going to lubricate the back of the LMA. I'm not going to lubricate the front because that's where that's going to cover where the epiglottis is, right? So if I have this here, that little flap, I'm trying to place it inwards and over the flap. So all you're going to do is you're going to ride the backside of a patient's mouth. You're going to put some gentle pressure, and you're just going to go, "Whoop," and that's it. You set up your LMA. Now, what I can do is I can take my mask off my patient. Again, this would be set up at 15 liters per minute if I haven't mentioned it before. Then I can administer some breaths. Okay. And if I had the chance, what I would do is I get a stethoscope and I listen to lung sounds, make sure I hear decent lung sounds. I'm listening to the abdomen, making sure I don't hear any breaths from the abdomen or very diminished because it's not an ET tube. It's not going to be a secure, proper airway. It's just going to be like a supplemental airway. It's not as definitive as an ET tube. So administering breaths. And what I actually learned recently, which is very cool, is I don't even have to take off my BVM and maybe I have capnography set up too at the same time, right? Or maybe a colorimetric device and I'm messing with that. Although really capnography would be the way to go for this. I can stick some suctioning equipment and I can thread it down into here. As you can see, there's actually a little port for suction equipment. We can thread that down. We can start suctioning the patient just in case we get any fluids. And again, it just slips right in like butter. Super easy to use. I can breathe for my patient. Very simple. And then I know that my LMA is secured. I can have a partner set it up like so, but you'll just sneak around. I don't want to really get this out of the container. We're just going to be careful with our patient. I don't want to take them out. But basically, these two straps this will go behind the patient's head and be supported. Whoa. And then these two will connect right here and then right here, like so. And it'll be secure on my patient. That looks really dumb. Let's just do it, right? Get out of here. We'll fix it later. Okay. So I have my partner holding the LMA or vice versa. Then I'm going to sneak underneath their head. Then I'm just going to pull with decent tension. I'm going to secure it here. Same thing on this side. Secure it here. And then I can breathe for my patient. And it's fairly well secured now. So don't be worried about it. They make these things dummy proof, you know? You might be a little worried, a little shaky. I get a little shaky too, but it's fairly simple. Let's see. Do we have any questions? Uh, oh no, use hand sanitizer. Oh yeah, nasty, nasty. Does anyone have any questions about EMS at all? If not, I'm just going to keep moving forward and talk about different topics. But we'll breathe for our patient there. Let's see. I know somebody talked about uh, an acute myocardial infarction, an AMI. You talked about confusion, things like that. So it might be something that we want to touch up on. Now you're a mess, buddy. Now you're kind of making me mad. We'll have to clean you up later. Anyway, let me see. Any questions? If not, I'm just going to keep moving. All right. Let's talk about something that I love talking about. And I just taught a stop the bleed class. We're just going to kind of close you up and move you out of the way. We can maybe adjust the zoom in. Uh, bleh. Oh, that's a manly way to put that up. Okay. Let's talk about trauma. And more so, let's talk about if somebody was shot. Now, I just taught a stop the bleed class. I had a lot of fun with it. And so I'll kind of go over you guys with some of the stuff, and then eventually I'm going to make my own video going over me teaching a stop to bleed class because I think it'll be a lot of fun. So I'll answer that question in a moment, sir or Miss Rami, whichever one. Anyway, let's say they get shot in the arm. What do we want to do first? Well, first off, we want to make sure that if they have an exit wound, we're watching for that to make sure it's not also bleeding. Let's say more so they got a laceration and they're spurting out bright red blood. What are we thinking there? If we see spurting and it's bright red blood, we're thinking, okay, it's arterial or it's an arterial bleed. What do we need to do first? Don't underestimate in real life. Apply direct pressure. Apply compression or pressure directly to the area. Have some gauze on you, of course. Have your gloves, like your PPE, of course. Apply direct pressure with some gauze and leave it there for a bit. See if that works. I've had multiple calls on scene where I have a cover with a gloved hand. Exactly. Preferably if you have some gauze, but if not, I mean, if you just have a gloved hand, you just need to slap it on real quick. Go ahead while your partner is setting up. Hopefully, you have a brush or an engine on scene or on the way, and they can provide extra hands to assist you. But you should always have a partner that should help work with it. Anyway, applying direct pressure with gauze. Next thing that we want to do, okay, the bleeding's not controlled. We need to apply a tourniquet. So I'll take a tourniquet like so. And non-sterile versus sterile dressing use. If I can help it, I'll use sterile dressing. But if it's an arterial bleed and I need to stop it quick, I mean, if non-sterile is available, maybe I just do that and they can just get some antibiotics later. I mean, right now I'm just trying to create a clot if possible. And if it's an arterial bleed, it's going to take a while. It's going to be tough. But of course, sterile if we can help it with everything. So I apply my tourniquet. This one's not properly set up, but I'm going to twist and apply it appropriately. Actually, if they're spurting right here, I really should move it up a bit more. So we'll say right about here. Okay. So apply a tourniquet. We'll twist appropriately. Also, if you have a tourniquet at home and you want to mess around with your tourniquet, be really wary about twisting it because technically, once you twist it at all and you manipulate this piece right here, technically out of service and it shouldn't be used in an actual medical call. So have your training tourniquets if it's possible. Just be aware once you start actually twisting this, it's technically out of service. Okay, so normally this is where we would stop. This is for training though, so it's fine. And we would keep twisting till the arterial bleed stops. Afterwards, we're gonna label it like so. Put our date. Make sure if we put like regular time, we're putting the actual date and the time. So I like to put AM, PM. Make sure you put AM, PM. You need to make sure you put the date because let's say you put like 10 and you don't put 10 p.m. and that's how you put like 10 o'clock. They go to the ER. No big deal, right? Let's say they have them for about like 12 hours or so and or let's say 13 hours and it's 11 a.m and the ICU units with them for whatever reason, they're like, "Hey, maybe we should consider taking out this tourniquet. It's only been on for an hour, but because you didn't put a date and time, it actually could have been 13 hours. All that sodium, that acid's going to build up and send off straight to the heart, and you'll potentially kill your patient that way. So it's really important that we put the date and the time for a tourniquet. Okay. Textbooks are really big about pushing for tourniquet use. I am not a big fan of tourniquet uses. I like applying direct pressure to the wound. I like having somebody show up and I like saying, hey, can you apply direct pressure? You're going to do that the whole way to the hospital. That's fine. Because whenever I'm applying a tourniquet on a patient, it's not one twist to stop an arterial bleed, especially if it's in the leg. We're gonna have to twist, we're gonna have to keep cranking it. I don't really want to do it to myself right now, but we're gonna have to crank this bad boy probably 12, 14, or not 12, maybe like 10 to 12 times before we actually stop an arterial bleed. And at the same time, it's gonna hurt so bad that the patient might actually start to say, just take it off me, just take it off me, let's do something else, even though that's the only thing saving them. It's really painful. The Sam XT tourniquets, that's the one, those are super cool. I like using the Sam XT tourniquets versus the CAT tourniquets. However, you need to train with them. A lot of people think that, what is it called? A lot of people think that it's really easy, but whenever they put hands on it, they're like, "Oh man, I might actually not know what I'm doing." You're talking about the one that clicks kind of like a seatbelt, where it has the two prongs, and you click it. Once it's clicked, you're good. Then you can just twist. I love those things too. But if you work at a department, check with your supervisor, check with your EMS captain, whoever it is, and make sure you guys are doing proper trainings every 6 months or a year. A lot of people will mess up. If you are familiar with what you're talking, what she's talking about, you can pull them up, and then that releases the prongs and it retracts in. But a lot of people will take their thing and then try to stuff it into there whenever they're trying to lock it. Um, so it's really easy to mess up on a SAM XT tourniquet. The CAT tourniquets, there's really no way to mess them up. The SAM XT tourniquets, you need a little bit of training, and that little bit can potentially cause somebody to bleed out while you're messing up with them. One number one screw up is not enough pre-testing, really, and you're right about that. But for the SAM XT tourniquet, again, a lot of people forget that you're not supposed to stick that into like the seatbelt little thing that says pop open here. That's to release the pressure or the prongs. So be real careful. So let me talk about this excited delirium, then we're going to go more into it. So Rami said, how do you deal with a patient exhibiting excited delirium? It's a great question. What is excited delirium? So I saw somebody commented on it. So let's see. Mr. Mailman said, to be honest, most important thing is to try to calm them down. You're exactly right. That's why I like 7XT. Okay, number one screw up. Okay, I've never seen these. All right. So if I have an excited delirium patient, you will love them, by the way, Mr. Mailman, but be careful. You need training with them. Otherwise, you're going to potentially hurt someone. Uh, if we have an excited delirium patient, what do we need to do? First, most of the time, we need to have PD on scene. I don't like to be the bad guy, but we have to consider scene safety. A thin, frail, uh, not to be like gender biased, or like let's say like a thin, frail female that's half my size that's suffering from excited delirium where she's having a psychiatric episode can easily destroy me and overpower me. They just have crazy strength emanating from their psychosis. So be really careful with them. What do we need to do whenever I have a patient going through any type of psychiatric episode? I said, I got to be careful with this. It's my table anyway. I'll sit down with them, right? If that's my psychiatric patient, I'll just look at them in the eyes and I'll just talk with them. Be like, I'll change my tone, right? I'm looking at them directly in their eyes. My hands are non-aggressive, right? So I'm keeping kind of a relaxed approach. And so I'll talk to him like this, right? Saying, hey, sir, what seems to be the problem? What's going on? Like, I'm not having a loud, booming voice like I'm trying to do to talk to you guys. Instead, I'll have try to have a real pleasant demeanor, try to calm them down, say, "What's going on?" Blah blah. I try to find out, hey, was they potentially considering? I can't say it on YouTube, but injuring of oneself or so forth. I can't really mention that. I don't want to go any further into it. But if they are considering something where it's going to injure themselves, then I may need to go a route where I talk to PD and we get EDW or an emergency detention warrant. Where at that point they need to go to the hospital. They don't have a choice because if not, if I leave them alone, they're going to potentially injure themselves. And so we need to get them to the hospital. And if an EDW is the way to do it, then so be it. But I'll try to level with them, be their friend, talk to them, and I'll just keep them calm the whole ride there. I've had one patient before where he was really amped up. He's like, "Oh, I'm so angry," blah, 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 and he's looking at everyone all angry. And I show up, and I'm the paramedic, right? So I have access to sedatives. I'm like, hey, sir, would you like it if I gave you something to help you relax?" And then he looked at me, he was like, "Yes, please, I would like that." I was like, "I like that too." So I gave him some a sedative like Versed, which EMT-Bs can't administer, but I can as a paramedic. I gave him that to just calm him down a little bit, relax, just drove him to the hospital. Worked out perfect. I've had it before where I worked at it with this was a different agency, different time, nothing that I mentioned so far, where I had a female patient that was in the ER and she was erratic and blah blah, and 10 different nursing staff along with like the officers at the hospital had to like calm her down, give her Ativan, and try to relax her, right? And so they calm down this crazed patient that's like beating off everybody. And then once she starts to relax a little bit, they're like, "Hey, Mario, can you go ahead and transport the patient?" So I'm inside the back of the medic unit with this patient that was kicking everybody's butt, right? And it probably kicked about 10 people's butts. And so I remember she was sitting down in the stretcher, and then she's like, calm down, her eyes are drooped. And then all of a sudden, she just opens her eyes and she looks directly at me. I'm sitting in the captain's seat. I'm like tapping my iPad. I'm like looking up, like, okay. I'm not making direct eye contact because I don't want to aggravate them any further. And she sits up and she turns and looks at me. And I'm like, and she's like pulling a little bit of restraints. And I'm like, hey, uh, you want me to loosen your restraints a little bit, keep you kind of relaxed? And then she's like, and I'm like, I don't know what to do. And so I pretended to loosen them a little bit. I'm like, hey, it's okay. Let's just try to relax. I didn't do nothing. I'm gonna tighten them up a little bit more. And she was like, okay. And she just sat down and was like this the whole time. And I was like, if this lady breaks out, which she can at any moment in her choosing, she will destroy me. But she didn't, because I was really sweet to him. But somebody, whenever I was getting ready to transfer my patient, they were like, "Ha ha ha, that's what you get." And I'm like, I'm about to transport this crazed patient, and you're mocking them as I'm about it. You're a bad provider, whoever you are. But also, I'm the one, the only person in the back of the box that's gonna be dealing with this person that can kick my butt in front of 10 people, and you're gonna be talking mess. Leave my patient alone. Right? So just get him away from that person. But yeah, just shake the bees before you hand them to me. Let me read some questions here. From a group, definitely get that one. Yeah, for sure. Next question. Have you ever been attacked by a patient? No, because I'm always really kind to my patients. But I was a student one time. So personality does go a long way in the field. You're absolutely right. A&M did tell him. Uh, let me reread that question. So Megan asked, for next question, have you ever been attacked by a patient? So I was doing my write outs one time. We had a drunk patient covered in blood, and he ended up vagueling himself out from straining so much in the handcuffs, right? And he's like doing this the whole time, right? He's looking really aggressive, and then he compresses his vagal nerves to the point where blood can't shunt to his brain, and he passes out for a bit. And he has like a syncopal episode, but he goes back to normal. We don't have to do CPR. It's fine. It lasts about 5-10 seconds. Where we're just watching, like, do we start CPR? No? Oh, you came back? Okay. Then he was like semi-conscious, like almost unconscious. Brought him under the stretcher, still handcuffed, or not handcuffed anymore, because we have to consider CPR. So they had to handcuff him. So we're heading out to the hospital. Probably about, I would say, as we're about to pull into the hospital, like we're starting to back up. He when we started giving him, I don't even know if we gave him some fluid. I don't think we got the IV. He my lead medic, I'm a student, is this female. She's really strong though, and she's really was a great paramedic, great to watch in the field. And he looked at her, and he's like, "Oh, I don't even want to be here." And then he punched her while he's covered in blood, right? And he punched her, and then I'm sitting on the side, right? So she just got punched on the side. Some blood got on her. And I'm like looking, and you think hero, think again. He turned, he looked at the exit, came out of the door, kind of swatted at the guy, and then ran away. And then we had to call the cops and do all this other stuff. Uh, but I first off, I don't want to put hands on them because again, they're going through a psychiatric moment. Like the last thing I want to do is assault my patient. But I'm real glad he turned to her and punched her and not me because I was like, I don't want to get hit, you know. So I came close. I've had a couple crazy incidents, but I've always been really good about having a calm, nice demeanor, and that's worked really well for me in the field. I'd highly recommend being nice to your patients because even the crazed ones, they'll be nice to you too. For whatever reason, patients love to dislike cops and then love EMS, which is great for my field. I feel bad for cops. I made a video about it where cops will say, "Hey, sir, we just need to check you out," and I'd be like, They'll be like, "Oh, I hate you. Get away from me." And then I'll be around the side and I'll say the exact same thing. I'll be like, "Hey, sir, we just need to check you out real quick and check out your vitals." And they'll be like, "Oh, okay, okay. You know what? You're right. That makes a lot of sense. But get him out of here." And I'm just like, "Oh, that's kind of you're very aggressive." But I guess as long as it's not to me, I feel bad. I'm talking to the cops on the side afterwards. I'm like, "Hey, like as we're packing them up, I'm sorry. You guys are doing the right thing." And they're like, "We're used to it." It's tough. All right. Let's see here. Uh, how should you touch up on remembering the placements of the 12 lead EKG? Also, remember the use of the heart muscles. Uh, Great question. EKGs are, you should consider them as dummy proof, or they're very simple. Okay. I don't have a good imagery of them here, but you have some people memorize the colors. Get that out of your system, okay? I've heard somebody give me a full inline detail where they're like, I don't know the colors. They're like, yellow is to the side, and then red is to the heart, because green is to the this, because blue is to the this, and purple is to this. And then they know the whole like coloring system. Okay. Don't memorize it by colors. I cannot stress that enough. It was so cool. He had the coolest acronym set up for uh for a 4 lead or a 12 lead. It's a bad idea. Instead, remember like this. You have your right arm, your left arm. You don't want to put it on bones, right? We want to put it kind of in like the fatty tissue right around here. Okay, so I'm looking at my patient. I would consider putting it right around right here, right? Not on the acronym or acronym, I think is what it's called, something like that. Right about here, right about here. And then we use the body as landmarkers all the time. And so if I have my belly button right here, I'm gonna go on the side. And there's gonna be an RL and an LL. Right leg, left leg, just on the sides of the belly button. Uh, and then for the torso, right arm, left arm. That's as complicated as it gets. You could also choose. Let me get a chair. Is there a chair? Is there a chair? Chair. There's no chair. I just stand over here. You can choose to put it on the forearm if you'd like, or you put right arm, left arm. You can choose to put it on the calf if you'd like, although some people say you can't. Oh, you can put the right leg on the fatty part, like where the calf's at, but do right leg, left leg. That's fine if you do that for those 4 leads, but you cannot do something like right arm, left arm. You need to keep it parallel. Okay. Some people will swear that you can only do it on the chest or the torso and on the stomach. Some people will swear that you can only do it on the forearms and the calves. My opinion, doesn't matter. Okay. You're fine. Unless they have an amputation or something weird. Uh, if you want to start off with learning, just do the right arm here, left arm here, right arm here, left arm here. But what's great about doing the biceps and the calves is we don't have to move their shirt at all, right? So we don't have to be as invasive, which is always really nice. Now, there's V1 through V6. Okay. Now, for V1 through V6, remember that our heart's going to be kind of towards like the left side a little bit, right? So that's where our heart's going to be at. So we do V1 on the right side, V2 on the left side. They're going to be parallel to each other. Then we take V4, you go underneath the nipple. V3 is going to be in between these two, kind of more so underneath the breast. So right about here, right? So we have V2, V3, V4. V4 is underneath the nipple. V6 is going to be mid axilla. So V6 is going to be right here. And V5 is going to be between V4 and V6. Okay. So we use the body a lot when we do EKGs. So V1, V2, or sorry, right arm, left arm, right leg, left leg. It froze. Hopefully it unfreezes. I apologize for that. How about now? Is it frozen now? Like Frozone from The Incredibles? What does he say? I just need a drink. And then he drinks it and freezes the cops. Ah, anyway, okay, it's good. Fantastic. I apologize for that, Megan. Don't worry. I'll be able to publish this video afterwards. And I try to set it up so I can see the comments afterwards because I feel like it's fun. But this video is going to be live in the channel in maybe an hour or so afterwards. So if you miss some of the topics, if you're like, oh, I missed half the stream, it's going to be available on the channel in the live tab. Anyway, again, right arm, right leg, left leg. V1 and V2 are across from each other. V4 is underneath the nipple. V3 is in between V2 and V4. V6 is mid-axilla, and V5 is in between. Okay, so just going around the breast. Also, you can, once you get good enough at EKGs, you don't have to go up to a girl and flash them. Okay, you don't need to lift up their shirt to set up an EKG. It's very simple, even if they have very large like breast or whatever. You hug it around the breast as I'm setting up for V1, V2, V4, V3, V5, V6, and so forth. And we can kind of even have them kind of lift up their own breast, and then we can kind of use their shirt to kind of pull up against it. We don't need to. 99% of the time, there's no need to ever like expose the nipple. Now, I'm not saying to prevent care, and if it happens, it happens. It doesn't make you a creep or anything. You just have to set up an EKG, but try to preserve some modesty. If you're able to set up an EKG or a 12 lead on a patient without exposing their breasts, it's always the way to go, you know? And so I try to do that whenever I sit up with patients because I try to give them that extra layer of comfort. But if I am working like cardiac arrest, of course, shirt's coming off. If I need to expose anything, if I'm worried about like an injury and it happens to be right by a nipple, okay. I mean, it is what it is. I have to look at the area to make sure there's no significant injury. But just try to be respectful for your patient. Modesty is so important. Just like a cardiac arrest, we'll try to cover our patient. Let me take a look here. Let's see some of these comments. Megan, I hope that answered your question. And then for Sharon, I hope that answered your question. I hear stories about females getting hit. Yeah, it's sad. Yeah, smart dude. I know. Okay. We step out of the way when we have swinging, bloody patients. Just because you're kind doesn't remove the entire chance when you're dealing with an extremely crazy, violent patient. Exactly. So have PD on scene. Sometimes they need to go in the box with you. That's okay. You got to be smart too. And sometimes you are just going to get hurt, but try to prevent it as much as possible. Okay. Uh, let's see. Personality definitely goes a long way. I agree again. One of my student clinicals, I had a psych patient that wouldn't give us any information. I asked her to at least give me your age. He said, I'm 157. Just leave it at that. The hospital staff can deal with it. I mean, at a certain point, there's nothing you can do. Maybe whenever they talk to somebody else, it's really funny. You'll pull them into the ER, and then they're going to be like, "What's your name, sir?" And they'll be like, "My name's Mario, and this is my date of birth, and this is that." And you're like, "I've been asking that for 20 minutes. Is it just a new face? Do you not like how I look? It's because I'm sweaty. Is that it?" So don't be worried about it. I mean, sometimes if you can't gather patient info, it's fine. Uh, let's see here. I heard about that. I knew them by V1, V2, V3, etc. All right, Mario, thanks so much for the time. Oh, Pikachu says, I got to hit the hay. Keep up the great explanation. Thanks, Pikachu. Let me see, Megan. Clouds over grass, smoke over fire. Clouds over grass, smoke. Is that the colors? Megan, get that out of here. We we don't need colors, all right? We just need to know the limbs, okay? Uh should have restrained him and administered antipsychotics and put him in a straitjacket. No, 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 no. We got to be nice to our patients. We don't. That might be movie stuff. That's not real life stuff. He refused care, and we just left him with the poor cop. He took the door handles to his mom's door and filled the toilets with fecal matter. It sounds horrible. Um, let's see. It did. It did. Thanks. It did help. That's fantastic. That's what we aim for. Trying to help you learn more about EMS. I'm gonna head out. I'll see you around, Mario. Thanks for the fun nights, Mr. Mailman. I can tell you're already a really good medic. I'd love to see you in the Discord if I haven't already. You should definitely say your name so I can check it out. But you seem like a very talented medic, which I'm assuming you are, unless you're that psychofusion scientist that they were talking about. It was bad. Yeah. Anytime you deal with fecal matter, I mean, that's just a really bad call. It's really unfortunate. Let's see here. Hello. All right. In the Discord now, I'm an EMT. Well, bro, what the heck? Mr. or Miss? Well, you say Mr. So Mr. Mailman? Mr. Mailman, it's time to become a medic. How do you know all this medic knowledge and you're not a medic yet? You need to pick it up. You know too much as is. I'm in nursing school. Fantastic. We will be best buddies because I've just done the orientation. It's crazy. They had an orientation for 2 days. And for the bridge, they had a mix of bridge program students and regular students. And they were like, "Hey, bridge program students, You don't have to show up the second day if you don't want to, but we are going to go over some med math and medical terminology. You guys might know it. And I looked at my buddy Fabian that I'm going through the program with, and I'm like, yeah, we're going to the second day. I already have the day scheduled. And what kind of chump would not go to the second day for orientation, right? Because they think that they know what they're talking about. We showed up. There's like three bridge, as far as I know, like three bridge students out of the excess. And I was like, guys, we thought that this was mandatory. We had the day set off. What do you? I mean, life happens, but what are you doing? Like, it's okay. You got to lock in. You got to lock in. That's okay. They have their own lives and they get to choose whatever they want. I took the NREMT Wednesday and sadly didn't pass. I needed 950 and made 937. Gonna wait 15 days, but I know I'm gonna crush it next time. I appreciate your study guide. Joshua, that's what we love to hear. Keep it up. I filled my NREMT-B twice. Passed my paramedic on the third time. How do you get into the Discord? It's in, I have it saved still. There's a link to the Discord. Also, in every one of the video description, there's a link in the Discord as well. But please join the Discord, ask me questions. We love to talk to you guys. Uh, it's a lot of fun. But let me see here. Yeah, technically, I'll be with you. I'm starting the school in the fall, but found out I got into the program a few weeks back. Congratulations. Thanks for telling me. I was really bummed. Yeah, I failed my NMCB twice and I passed on the third try. You know what happened? I went in, I took the test, I got to 60 questions. And I was like, that was really fast. Did I kill it? I failed. I did the worst possible score. Took it again, got to 60 questions, finished it, got kicked out, and I was like, did I score really bad again? I failed. Third time I went in, I had like 66 questions, I believe right around there. And I was like, oh my gosh, I failed. I just keep on failing. I killed it the third time. And this is with nonstop studying. Sometimes it's the luck of the draw as well. Don't be discouraged. You get 6 tries for a reason, three, and then a refresher, and then three. Message us at any time. Message me at any time. And I will do everything in my power to help you pass the national registry. That's what EMS educators are all about, is helping the students pass. Uh, and ask questions. And if you don't know what questions to ask, I will know what questions you need to ask, and I'll help you with it. Okay? So let me read here. Let's see. What's on the NREMT? I would recommend looking at the study guide video. It helps a lot. Also, in about 2 weeks, guys, I mentioned it before. I am working on a website. It looks horrible. Because you've been around here so long, I will tell you the website. There is nothing on it. It's amateurmedicine.com. Took a lot of work to set it up to be clearly stated that way. You want to know what's in it? Nothing. So don't type it in right now. You want to ask me about Discord, I can answer you. There's nothing in it. What will be in there shortly, though, is 500 practice questions. Not just 500 practice questions. I'm also going to do 60 questions. They're going to be 20 GCS questions, 20 APGAR questions, and 20 rule of nine questions that you'll be able to go with. Also, there'll be a vital signs question. Also, there'll be a freebie section. There'll be one other thing, and it's all going to be in a bundle for you. I'm going to sell it, and I will tell you the price of it afterwards. But I promise you, it's going to be a very fairly priced program because I've seen my other competitors or other fellow educators. And I think, you know what, if you charge too much, it's kind of scummy for EMT-B students, but it's a great value. I got a carpal tunnel making it. I think you guys are going to love it when it's ready. You message me in the Discord. I'll tell you more about it. I got to 100 questions. Definitely will, man. Or 109. Oh, 100. Man, you got 109. You know what that means? You're taking the national registry and you're like right on the cusp of passing and failing. You're right in between. A 937 is right next to 950. Okay. So you're like, if this is like the fail range, you're like right here, right? You're teetering because you're so close to passing. A 109 is a great score to have, especially if it's your first time. I had a 60 failed, which means that my score was as soon as it could kick me out, it could. 60, as soon as it could kick me out, it could. Just take a lot of pride in that and keep studying and message me. Message us in the Discord and we'll help you. They have a lot of great people in there. Thanks for telling me I was really bummed. Thank you. No problem. No problem. Just join the Discord. Fantastic. Well, we'd love to have you guys. One thing that I take a lot of pride in is our Discord, which I mention his name every now and then because I love him to death. Uh, I had somebody that one of my earliest viewers, Cool Breeze, messaged me on Discord. I've through comments because he would comment a lot, and I was like, "Hey, I love your help." And so I was like, maybe I should create a Discord. And so I was messaging him about it. And this is a random guy I've never met before. And he's like, you know what? I've helped with Discords before. Maybe I can help with you. The reason why my Discord looks so nice is because of Cool Breeze. The reason why the roles get filled so quickly is because of Cool Breeze. So if anybody's here right now and can comment, thank you, Cool Breeze, or clapping or something, I'd appreciate it because I really, 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 really appreciate Cool Breeze because the reason why our Discord's so nice is because of his hard work. And I really thank you, Cool Breeze. Thank you, Cool Breeze. I'm sure he's gone by now, but you're super super nice, super helpful. The reason why your roles get changed so fast, he beats me all the time, is because he changes them. Really amazing guy. We have a lot of great guys in our Discord and girls. Uh, and I think our community is just so lively. And it's just, and I love it because sometimes I'm not in there and other people are answering questions. And I'm so pleased where we're at, guys. If it doesn't even grow anymore, if it's just as it is, I think we've culminated something really special and I like to keep working at it. So that's why I always put the Discord link in the description. I'm a big fan of it. I love talking. I try to talk to you guys every day. Sometimes I can't. I'm too many busy on other things. I love communicating with you guys. I would reply to every single comment. There's a lot of comments on the YouTube videos. Let's go, Cool Breeze. I agree. Let's go. Uh, oh, Bronca, put a heart thing. Oh, yeah, that's cool. Let's go, Cool Breeze. Let's go. We love Cool Breeze. Any questions that you guys have? Anything that may be tricking you or bothering you? Is there something where you're like, I don't really know too much about it? Something that's confused you EMS wise. If not, I'm gonna start in about 15 seconds. I'm gonna start spouting out some random information, some things I think you need to know. But I'll give you guys another 5, 10 seconds. You think of any questions? If not, I'm just gonna start spitballing. Ooh. All right. Some things that we need to know in EMS. Let's think about OB for a moment. Let's think about uh, what is placenta previa? What is placenta abrupto? Oh no, freeze! Hey, frozone again. Freeze. I'm going to answer those questions first instead. How do you deal with tachycardia? That's a great question. How do we deal with tachycardia? Well, it's more so you just, as an EMT-B or an EMT basic, you really just need to recognize tachycardia. What's going on? Why is that happening? Why is the heart working faster? Is it because it's trying to compensate and perfuse the body more until eventually shock goes underway, and then now we start our blood pressure drops, maybe our heart rate drops. Really, blood pressure is more so the definitive sign for like a decompensated shock. Uh, and an altered mental status, of course, our patient presentation, blah 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 blah. But we just need to be able to really recognize what sinus tachycardia is. And whenever we see a patient's heart rate between 100 and 149 beats per minute, which is sinus tachycardia, we need to say, like, okay, well, what's going on? Maybe my patient really is in distress. Maybe this isn't GERD. Maybe he really is having a heart attack. Let's throw in some more stuff. Let's get a 12 lead involved. So it's kind of like an early indicator. Hey, maybe something's going on. Maybe they're septic. Have we thought about checking out their temperature yet? Why is their heart acting this way? A big thing that you need to know for your EMTB. There is a medication that you guys should be aware of that increases the heart rate. Ignore epi, by the way. It increases the heart rate when we administer it. Does anyone know what it is? It's an EMTB medication. It'll increase the heart rate when we administer it as a side effect. Anyone know? You need to know, and it's great to know. Got all these training bios, right? Don't worry, I have it over here. Albi? It is Albi. It's albuterol. Albuterol increases the heart rate of a patient. So I've had it before where I've had an asthmatic patient, a patient that is having shortness of breath, and they have wheezing. So those are clear indicators where, okay, and they have a past history of asthma, right? It's so super easy. I mean, they spoon feed it to me. Okay, you know what I need to do? I need to set up a nebulizer between 6 to 8 liters per minute because it creates a fine mist. I need to rip this open, pour it in the nebulizer, and I need to administer albuterol, right? So I'll create that fine mist at 6 to 8 liters per minute. That's the key. Okay. So we drip that in, we administer albuterol, and it opens up the lungs, but a side effect is it increases the patient's heart rate. So my patient already is frantic. They can't really breathe that much. Their heart rate maybe it's at like 98 beats per minute or 102 beats per minute. Now I'm at like 120, 130 beats per minute. But I show up to the ER. I've actually done this before where I showed up to the ER and like, hey, uh, patient's heart rate is at 120, 130. What's going on? Oh, and then I've had to tell them, oh, I administered 2 rounds of albuterol because their SpO2 is a little low and they had wheezing, but they seem to be good now. And they're like, "Oh, okay, that's why it's high." So just like a little reminder uh, that albuterol increases the heart rate. So expect it. Know what your medication does. So yes, it's going to fix their SpO2, their airway, which is top precedence, but also know it's going to spike up their heart rate a little bit. So really, just know to recognize sinus tachycardia. Know to recognize what the normal heart rate is, which is between 60 to 99 beats per minute. A lot of texts will say 60 to 100 beats per minute. I think it's inaccurate, but it's okay. Uh, but know that your drug can increase somebody's heart rate. So I see some other messages. I'm going to go to the next question, though. I hope, Rami, that answered your question about tachycardia. If you're a paramedic, please let me know because I can go way more into depth for sinus tachycardia if it's necessary, but I don't believe that it is unless you tell me to. Okay. Uh, and also know that 150 and above, we're thinking like, okay, now it's probably like SVT or supraventricular tachycardia, or is it something else going on? Are we unrecognizing maybe if it's a ventricular rhythm with a pulse? So interesting stuff. Anyway, I hope that answered your question. That last bit, you don't really need to know. Paramedics need to know. What are some volunteer or part-time things you'd recommend for new EMTs? So what are some good volunteer options? So Uh, one thing I take pride at the agency that I work at currently, at Annabelle Fire Department, is we're known as AVFD beforehand, or Annabelle Volunteer Fire Department. And so look at the county that you're working around. See, hey, maybe they have a volunteer program. It doesn't hurt to volunteer in your part time because you'll be around like-minded individuals that have gotten their EMT-B, that have gotten their paramedic, that maybe gotten their firefighter license, if that's what you're interested in, and then you'll be able to ask them questions as you're studying, and they'll encourage you to study and they'll encourage you to push. Maybe you volunteer for a little bit. Maybe they'll pay for your cert and then promise you a job for X amount of time. Maybe this is where you want to work at. It never hurts to contact your local agency that's nearby you and see, hey, do you have any volunteer options? Hey, what does it look like for me to get my foot in the door for your department? And maybe that's the first step you need to take to actually get into a department if that's what you're looking at. If you're interested in working for a private company, you're like they pay pretty good. uh, it doesn't hurt to say, "Hey, uh, do you do any shadowing or something?" Or, "Hey, I'm really interested in getting it. What are the prerequisites I need to start working at your agency?" And just getting your foot in the door, getting your name out doesn't hurt. So, contact your local departments. For us, we have a great thing. We're at Annabelle. You contact us, we'll set you up. Tuesday night training, we let volunteers come. From 7 to 9 p.m., we do an hour of EMS and an hour of fire. We also uh, just let us know, or even just, I mean, honestly, you could probably just show up and ask us. You might potentially be able to ride out with us, depending on how long you've been going to Tuesday night trainings. Be able to actually go on real calls with us, fires, uh, EMS calls, depending on how far we've checked you off. If you're if you have an EMT-B and you've actually gone off through the list, hey, maybe you can even ride with us too for fire calls. Hey, he's got his fire license, or he's working on his fire license. Maybe he can't be involved in the fire, but maybe he can help set up supply and work with the driver and see and visualize the whole time. Besides that, you're at the department, you're hanging out with us, hanging out with the girls, the guys, and you're studying the whole time. So it's a good environment, maybe away from home. You're eating with us, we're having fun. And as long as you have a good attitude. Now, if you're going to have a bad attitude while you're volunteering, don't do it. I've seen a lot of people volunteer spend hundreds of hours and then be miserable during the ride out. They're volunteering. I'm like, well, what are you doing? Why are you even? You're just making it harder for us to hire you on because now we're seeing your actual personality. You got to mask it or something, right? You got to know how to flip that off. I really hope that that answered your question, though, about volunteer fire departments. I'd love to answer more if you have them. Let's see. Do you have any tips for getting BP manually while on the back of a rig if you can't hear it? Yes. So, if I'm setting up a blood pressure on a patient, I don't have the equipment with me, unfortunately. But what I like to do is I like to get a blood pressure before I move. Take that extra 30 seconds or a minute and get your vital signs. Sometimes you're with a partner, and usually for us, it's a paramedic and an EMT will be a driver. And they'll be like, hey, you ready to go to the hospital? And I'll be like, no, I need another minute to like set up an IV on a patient, or need another minute to get a manual blood pressure. And I need to listen before we start driving because once you start driving, you might not be able to hear it. At some critical calls, we have no choice. But at that point, you can always do like a palpated blood pressure, uh, where you can at least get the systolic out of it. But I'm not too big of a fan of that or going over that. But yeah, if you're having trouble with it, I'd recommend just getting it on scene or before you go. Beware of orthostatic hypotension. What is orthostatic hypotension? Let's say, can I just, okay? You have me. I'm gonna get dirty, whatever. I'm a patient and I'm unconscious and I'm breathing on my own and I'm laying down on the floor. Get the blood pressure before you move me. Heed my warning, because when you lift me up and put me on the stretcher, you move me at any point at all, I may go under orthostatic hypotension, where my blood pressure will tank. And then if I'm at 60 over 40 units, now I'm at an unreadable range. So get your blood pressure early. Did I screw this? Did I mess this whole thing up? I hope not. Hello. I just love the glare. I wish I had a glare through the whole thing. I feel like that would just really complete it. It's like the sunlight. Anyway, sorry. Get a blood pressure before you move your patient. Okay. Let me take a look here at some comments. Look, I can kind of move the glare. Oh, there's a second glare. Fantastic. Let's take a little look see. I hope that answered your question. Get it before you move your patient. Get it before you drive away, and then you should be good. Hopefully, if not, then work with your partner to obtain one before you leave. Because if it gets too noisy, there's nothing you can do. So I've had a couple questions about shock on my practice test. Is it more important to administer oxygen or provide warmth? Both are really important. Oxygen first. It's my personal opinion. ABCs, airway, breathing, circulation. If you need to do BVM for a patient or set up a non-rebreather, a nasal cannula, so be it. For whatever reason, do that for your patient. If I have an unconscious patient, 90 or so percent of the time, I'm using a BVM if I'm going to answer that as my national registry question. Oh my gosh, you can see all my sweat. Guys, the AC is broken here, so I need you guys to give me mercy about this grease and the sweat, okay? So there's ain't nothing I can do about it. Uh, let's see. But remember your H's and T's. If I worked up north more, because I'm in South Texas, right? So it's really hot. I don't really deal with hypothermic emergencies. If I have a patient I pulled out from a cold environment, you're laying down on concrete, so they're losing heat constantly. Let's say it's like 40 degrees or 30 degrees outside, somewhere extremely cold, then hey, I need to actively rewarm this patient too. So while we're actively rewarming them, if they have a low SpO2, I'm breathing for my patient too. ABCs will kill your patient before anything else. Okay. And then if they have a trauma, it's CABC or critical life leads, airway, breathing, circulation. Watch out for that. Uh, let's see, nitro vasodilator. I think that's whenever you're talking about the slow heart rate on a patient. I've had some classes, time it's I took some in class one time for funsies, gave me a bad headache. That's a very interesting idea. I would not recommend that, but that is interesting. Cool breeze. Who I give you a headache? I don't know. Just don't do that. All right, don't do that. Fun fact: at Mississippi, we can't administer any medication. We can only assist the patient if it's prescribed to them, and if they have it on their person. Okay, then Fun fact about Mississippi, at least for an EMTB, that's what you got to do for your local agency. Think about it this way. I mean, it puts less liability on you, less interventions. You're still getting paid the same. Okay, that's what you have to do. That's what you have to do. And then push for that. I always say push for more education. So with more education comes more protocols, more reach on what you're able to do. But in the meantime, just in Annabelle, I don't have surgical crack protocols. I don't have protocols for RSI or rapid sequence intubation. You know what I say to that? Then I can't do it. Okay. Now there's certain emergent situations where I can contact medical control and be like, I have this pain medication, this sedative. What would you like me to do? I have scalpel from the OB kit. What would you like me to do? Yes, I have that option. But for the most part, it's just comfortable, right? It's one less thing I have to worry about compared to whenever I did used to have access to that at a different agency. And then I would have to learn that. So don't worry too much about it. Enjoy it, study, push for more access to medications. Let's see. Echo Core 500, I don't know what that means. As an EMT-B in Arkansas, we are allowed to administer some medications, but only a few. That's okay. Because you know what we do? We study in the meantime, we get more access to medications. Oh, there's a water bottle. Oh, thank you. A lot of chatting, but I love it. You should see me at Texas EMS Academy, where I work part time. Uh, I talk, except for the breaks where they do quizzes or tests. I'm talking like 8 hours straight or something. Oh, that's good. That's good stuff. Sorry if you had to hear me gulping. Let's see. Echo 500 is that nice bougie noise canceling stethoscope. It's funny. My partner, well, one of my coworkers actually bought the Echo, and then I was looking at my heart, but I wasn't looking at the right place, and I was like, "Am I having like a heart attack?" And then I moved it, and it looked fine. But I freaked out for like a good 30 seconds. It gave me a little mini heart attack. I'm not too big of a fan of those. They're very nice. They're very expensive, but that means they're easy to get mm, to go missing or somebody take it while I'm not looking, or like if I leave it on the box one day on accident. So the highest I would go is a Littman, and I leave it in my POV. I wouldn't even take it to work. That's kind of how I go about it, but it's your choice, of course. If you have it, I mean, use it if you want. It's a good tool to have. Let's see. As an ETB, do you like graveyard shifts, and does it get creepy or scary at night? So the creepiest thing for me all the time is whenever I have a call where I have a patient that we're not sure about. Let's like say it's a wellness check and it's an old person. Is whenever I have to break into their house, right? Like let's say I have to check on the windows and they're so scary. Where the medic unit and the engine's on scene, I open up a window and like, all right, well, hello, fire department. Nobody answers. Okay, I gotta go in and pop open the door. I've had it before where an elderly woman was supposedly she had a weapon, but PD went, they cleared the scene. I showed up later. She's a sweet old lady. I'm talking to her. She's laying down on her side, and as like I'm talking to her, she's so nice. I roll her over to her side. She's got like a revolver, like that was stuck on her fat. As I moved this old woman, and I was like, ah, and then I put us in between it, and I was like, okay, well, let's get you over here. But I mean, she was super sweet. Breaking into people's houses is the scariest thing. Whenever you don't know if you're gonna have like a veteran or something that may be having a some type of disturbance. Bless them, of course. We love our veterans, but they can be very dangerous depending on this call that you're at. So those are the scariest calls for me. And dogs, you don't know about dogs, whether they're gonna bite you or not. I'm not a big fan of dogs. I do. I mean, I love the dogs in my life, but wild random dogs, I'm not a fan. But to each their own. Rami, it's a side effect of medication when you're using it on a patient that needs it. I think we're talking about albuterol. The headaches that can occur. You're right about that, Cold Breeze. Of course he is. Of course. Uh, how do I hold on to my skills while working IFT? Uh, listen, you don't. You don't. I'm sorry. Uh, training, training is the best you can do, and keeping fresh. You're trading you're trading your skills for a higher pay, uh, and it gets complicated later on. If you train, I've known IFT. I used to be IFT also, or interfacility transports. It's where you're doing private instead of 911 calls. You get paid more. You get a lot more calls, but you do a lot less because you're only going from hospital to hospital. Everything's situated. It's very easy to lose a lot of your skills. That's unfortunate. What would I recommend doing? I always recommend more education. But studying on your own free time, maybe bringing it up to a supervisor and be like, I need to study a bit more. Talk to a coworker and say, hey, can we refresh on that? The great thing is, if you're working IFT, you're working with a lot of like-minded individuals, and hopefully they're EMS oriented, since that's what they're focusing on. But it's tricky. Yeah, it's tough. You're in a tricky spot. You might lose some of your skills, unfortunately. Let's see. Do I keep it in my back pocket? I Good luck. I'd keep a handcuff on it, or I keep some kind of retractable thing on it if I had the Echo. Uh, I hope that answered your question, Final Fantasy. It's not a great answer, but it's tough. Uh, other excess videos can help you out too. Starting EMT school in the winter. I'm in Virginia. I want to be super prepared. What can I study with Reed? Nothing. Nothing. Go in with an open mind and have fun. When you sit down, show up early, have all your stuff ready. Uh, Preview the PowerPoints beforehand whenever you're going in for, like, let's say chapter one. Go in with a great attitude. Drink some coffee, wake up early, sleep well the night before. It's all I'm going to recommend for you. Don't bother doing pre-reading. Okay, just go in there and have fun and be the best EMT-B, the best medic, the best AEMT that you can be, or whatever you're doing. Just throw yourself in the program and enjoy every moment. Just know it's a privilege to be able to learn what you're learning. It's a blessing that our minds have got us to the point where we're able to receive this new knowledge that can impact our life every day. And so that's kind of how I treat it. I just treat it as, like, I'm so blessed to be sitting here listening to this person talking to me about this info that I love learning about. And that, I mean, I don't drink energy drinks during lectures. I drink energy drinks afterwards. Because I'm like, okay, now I need to do some self-studying on my own. But I'm enthralled for the most part. And it's an absolute pleasure hearing different interpretations of EMS. I can't wait for the RN program, 'cause I can't wait to learn all these things that I didn't know about before. And I think that's the mindset you have to have. Is just know that you're you're in such a grateful position just to be able to get a new perspective on this, right? And then enhance your skills. So that's how I look at it. But to each of their own, you'll have your own ways of interpreting it. And that's what I'd recommend. Don't do pre-reading. Have fun. Talk to your person sitting on the left, the right, in the front, in the back. Change numbers and work together. That's your best bet for success. And work as a team. Let's see. I hope that answered your question. I assume you're interested in going to ER nursing. Would you be more inclined to the ICU? I work in med surg pediatrics myself. That's cool. Okay, so I'm thinking, like, oh, I want the hardest thing, right? So at first I'm like, I want the ER, and then I have a coworker who's just finishing. And he's like, yeah, I just got into uh, cardiac ICU for pediatric patients, and the kids are like this small. They're going through hemodialysis, and they've got 20 drips. And he was telling me about it, and I was like, you know what? I don't know if I want that. I'd love to learn more and explore the depths of it. I really want to get into the ER. I think that'd be fun. But maybe ICU is the way to go. I want to get my critical care. I wanted to get my critical care medic, but if I'm going RN, it's like, maybe just go for critical care RN. Uh, I want to do that, but I don't have enough experience, right? So even just him telling me that little bit about the critical care ICU thing for pediatric patients, it kind of put the shock back in me, where I was like, okay, I've dealt with drips, but that's a lot. And I have a child, so it might break my heart a little bit seeing something child pass away. And you may have to see that often in that kind of field. So in my head, I think big game, but I'm kind of retracting a lot of my what I'm saying, because it's like, well, I don't really even know how bad it can get, and it may be it may be a bit more tough than I can say. So I can't say I want to do the ER. Maybe I want to explore different fields. I don't know enough about nursing from that perspective to be able to really say what I want, but I know I want to explore it all. I'm not too interested in labor and delivery. I think that that might be the only thing where I'm like, I don't think I care for that. But anything else, fair game. I don't know yet, but I'm excited to learn about it. What if your sociopath can handle? Hey, let me just tell you, I can handle EMS just fine. I don't really care too much about that. I did have a pediatric code that was kind of bad. Not the best, but I went through it and I did what was proper. Uh, so I think I can handle it. I think let's not call us sociopaths. Let's call us people who are in love with our field and love helping patients and love working on critical patients to try to bring them back and try to bring them to life. Now, I love a good hard call. I want all my calls to be difficult in some way, but I also want my patients to have the best chance for living as they can. And so I study hard and I practice hard so that way I can give them the best opportunity because that's what I would want if I was in an emergency. So I would say sociopath. Let me catch up on these comments. Uh, let's see. I hope that answered your question, Manatee. But that's super cool that you are a med surg pediatric. That's really cool. I want to learn more about pediatrics. I think that there's such a cool topic and so dynamic. And so it's so critical that it'd be something I'm really interested in learning. But I can't say how tough I am at it because my pediatric calls are too few and far between. Uh, so IoT slowly kills the soul. This is my personal experience. I would recommend trying to get into a 911 agency ASAP. I would recommend that also. But if you need the bills and the money, IoT can pay you out. And when you go in, just be open minded and honest with your FTO. To an extent, yes. Uh, I'm an FTO at Annabelle. I'm one of the 3 EMS2s, and I'm an EMS instructor, fire instructor, and we've been rotating with some new field training individuals, or where I've been an FTO with my partner Fabian, and we just want to see a positive attitude. The worst possible thing you can see is when we're like, "Hey, we have to throw up ladders today," and then they're like this, or they roll their eyes. It's like you can roll your eyes, you can lean and do this, we're gonna have to do it either way, So this is just you showing me your character, like weakness, and I'll work with you on it. But I would, you roll your eyes, we're gonna do it. You thumbs up, really happy we have to do it. I'd rather work with you every day and have a more positive attitude. So just being positive and open minded really is important. Let me know your weaknesses ahead of time so we can try to stamp them out and hit them constantly. Don't be afraid. I always tell people whenever I'm training them, hey, we're 6 months in, and you just don't know how to throw up a ladder. We've just somehow missed it, or you just forgot, or you don't know how to properly roll up a line or throw out a line. If you're embarrassed telling everyone else, that's fine. Tell me, because I've been in your shoes before too, and I will work with you privately without telling you. And I'm honest with it. I won't tell anyone. We won't make fun of you. I'll work with you one on one, and we'll stamp it out quietly behind the scenes, so you don't have to expose yourself as maybe I'm like incompetent in the skill, which is okay. It's a failure on us training you that maybe you missed it, or maybe we didn't hit it enough times, or maybe you just need more time with it. And so I try to go into that kind of mindset as an FTO. I think it's really important because I struggle too on things that I should already know. So I understand. I sympathize with it. Um, yeah, that face said it all. I face it. It's been a while. I don't know what the face said. Was it a smile? But hopefully it wasn't for the sociopath question. But I don't know, Rami. Or for Final Fantasy. Rami says, "What if you're?" Oh, I already answered that. We kind of skipped ahead a bit. Oh, Chrono, I passed my EMT exam this week. That's what we love to hear, Okrama. Oberonka. I watched your exam prep the night before and it helped a lot. Thank you for highlighting some key things, like doing it for epiglottitis. Yes, sir. That's what we love to hear. That's why we do it, so these people can pass. And if you commented on the video, by the way, I get multiple, like a pretty decent amount every day, and sometimes I just miss it. But up in the Discord, say something, And a video, if I have a video that has like 500 or 1,000 comments, and I have a video that has one comment, It's a lot easier for me to see the comment in one video. I need to respond to Cool Breeze's comment in the last video. It's a lot easier for me to respond to this comment than it is for this one. So if I don't respond to a comment, just say it again over here, and I'll respond to it. I promise. I'll hit it up eventually. Don't be afraid to throw a couple texts, throw some free engagement for me. It's okay. But congratulations. That's from your hard work at the end of the day. So you deserve it. And I'm so proud of you. I definitely feel you about the PICU. Yeah, that's what it's called. The pediatric IC, the PICU. Lol, I find critical care way too stressful, so I could never, ironic considering I'm a big fan of your content. Oh, that just means you're more aware of it. Okay. So that's just more knowledge on your part to help you with that decision making. Uh, that's really sweet of you, by the way. But nursing is awesome, man. You'll do great, man. I'm so excited. Some background information about myself. I mentioned it one time, I think. A break table. Hey guys, little background resume for me. I started off in medicine, where I worked as a transcriber for a little bit. I was horrible because I didn't know what I was reading. And then I did maintenance for a little bit at a clinic. And I did that for a bit. Then I worked as an uncertified medical assistant for a while. And then after a couple years, there's like they have it called like, I try to ask questions, I try to learn along the way. The whole time I'm doing terrible in college. I was a really bad student at the time when I was younger. Then a position opened up at the clinic for like an advanced medical assistant. Like they're not like an RN or like an NP or something like that, but they know a good amount of stuff. The person quit at the place I was at, and they didn't have one for a bit. And I was like, "Hey, can I just kind of like sit in and like learn some things from like?" And I was talking to the NP, and I was like, "Can I learn some things?" And so I learned how to ask questions and how to get assessments done and what they're looking at and their thought process. I learned so much about lab values, things like that, maintenance medications. I'm so grateful. I can remember the NP that I feel like took me under her wing. Then eventually I was doing so bad in college. I was failing all my classes. I was horrible. I was like, well, doctor's out of the out of it for right now. Let's try my EMT. And so I didn't think they would accept me because I was so bad at college. And whenever they did, I was like, I can't believe they're letting me into this program. And I gave it all I had. I think that's what saved my college career. I turned it around. I got my EMT. Then afterwards, I got my fire license. I got my paramedic, top of the class, or right around there for all of them, right? Because I'm pushing myself to limits, like learning new ways. I know what doesn't work for me, so just don't do what I did in the past. Then I got into a department to have a lot of free time to study while I'm at work. I ended up getting my associate's degree in emergency medicine. Then I got my bachelor's degree and a really fancy degree in cellular molecular biology, minor in chemistry. I'm really proud of it. Now I'm going back for nursing. And I just didn't give up. I just kept pushing for it. But I feel like EMS saved me. So I'm really thankful for everything that it's done for me. So let's see. I don't really know how it went into that. Huh. Nursing's awesome. Yeah, oh, nursing's awesome. I guess that's kind of how we digress. I'm super excited for nursing. I I'm kind of falling into the pitfall where the guys like, should I do some pre-reading? I'm kind of like, well, should I do some pre-reading? I really want to, but I know I should just keep myself open-minded and have fun. I might read the first chapter just because I bought my books. They cost too much. So I might as well get some value out of them, right? Let's see. Tactical EMT. Hey, amateur EMS. Hey, whoa, your name's Tactical EMT? Hmm, that's a really cool name. That's like a slick, like, click them real quick. So you've got a really cool name on YouTube. I was like, is this guy that got like his own little channel going on? Let's see what's going on. Cool name, by the way. I did take a tactical EMS class, but it was only like a 3-day thing. I loved every minute of it. I got to like triage like a 30 plus patient mass casualty. So I was really excited about it. Uh, Kelsey Wong says, party face, party face to you, Kelsey. Rami says, what if your college career and cerebral functionality is all screwed up due to exposure of neurotoxins, water? what I think is going on and what I think is a real shame for college in general is you have students who aren't doing that great in high school. Your brain doesn't fully develop for, I think females is like 24 years old, guys is 25 years old. We push to go to college, even though it's not a good idea. You go in, you're kind of forced to go in, you do kind of bad, and then it's stuck with you for life almost, right? Like there's ways to recover, but it's really, really, it was so hard for me to get my bachelor's. I really had to fight and fix a lot of courses. Um, but it's a shame how at 18 years old, when your brain again isn't like fully developing, that's how I personally think about it, or you're not really who you're gonna be, in my opinion. Um, it's such long lasting life implications from doing bad early on. Uh, I wish that they push more for like, hey, maybe work a year or two and then go into college. Honestly, I think it's pretty stellar advice, unless you're really like a straight A student. You know, sometimes you need to suffer a little bit and then be like, maybe I want more for myself." Not saying that not going to college isn't a bad idea. If you do decide that you want to go to college, like try to push yourself into some other way. Again, not saying that not going to college is at all either. Maybe if you give it a couple years, maybe you can go in from a more matured way. And so I wish, of course, you always wish you could go back and then do something like that. But I am where I am now because of my decision, and I'm really happy with it. I feel so blessed to even get my paramedic and then get my bachelor's, and now I'm going for my RN. So I'm really happy that I got all the way where I'm at. Let me see. No, I don't know the channel. It's just a cool name, by the way. uh, so no, I don't think it's neurotoxins. I think I was just not a great student at the time, and I probably should have taken a couple years off. That was my hand suctioning, by the way. That wasn't just letting you know. Honestly, man, I did not do a ton of reading in nursing school. These textbooks are super dense with a very small amount of testable information. Everyone learns different, though. Yeah, I don't really use textbooks too much. I like key terms and stuff like that, but I like PowerPoints and being able to pick out stuff. Uh, and then going through if there's like a little study guide packet or something, I will carry that packet with me, just like how I created for the study guide video for the EMT-B. I will walk around with that study packet from dusk till dawn, nonstop, and I will never drop that packet. I will work out, and in between workouts, I'll have that packet as long as I'm not at a public gym. I will eat and have the packet on the side of me. I will be hanging out with my friends, and I'm like, have the packet here. I did the fire academy while I was going through AMP2, and they printed out a packet like that. And I remember while I was going through my fire skills, while I'm waiting in turn to do a skill, I have my packet. I'm reading through it. I'm paying attention too. I'm like, all right, do a rope skill, go to the back of the line, read my packet. We're doing physical fitness and I have to jog with everyone. I was already really fit at the time. Now I got a little bit older, gained some weight. Could definitely use the work. Um, but I would jog with my packet like I was crazy, and that worked for me. And so that's why I made that packet for the study guide because it works for me. So when you get your RN license, will you divide your work part RN and part RF or FF? And congratulations again on getting the program. Miss Wong, Kelsey Wong, that's very sweet of you. I'm very pleased about it. It was a lot of work, but it was definitely worth getting in. I want to work at the fire department, and I want to work as an RN. Now, the great thing is if like let's say I get a back injury or something, I can go back and just work as a RN and hopefully not do. I know you guys still use your muscles. You're still moving patients. You're still setting up things, but I'm hoping you might not be as physically taxing as like a firefighter or like picking up the stretcher constantly as a paramedic. One wrong move and you throw out your back. So I'm hoping that it'll be a little. It's just giving me that extra option to be less taxing later on in life and then also gives me a chance to further develop my educational skills, which is that's the biggest crime in EMS is we stop our peak is really in associates. So I got a bachelor's, it's like, what do I do with it? There's not really much I can do unless you consider management, things like that. But it's like, oh, whatever, you can do that for anything. Um, but we really cap it in associates. And for RN, you go to a associates, bachelor's, then you can go for your master's, you can go for your doctorate. It makes a lot of sense. Uh, so I envy that ability to be able to scale up. Uh, the indomitable human spirit versus the technological, industrial, systematic, chemical society. Yes, well, let me make sure my phone's not gonna die. Oh, yeah, I got 12%. Whatever. Anyway, yes to that. The indomitable human spirit, my body will give out usually before my mind does, I found. Still learning and don't know much. Do you need to be an AEMT? No, you don't need to be an AEMT to be a paramedic. And some programs will not teach you that because they have an AEMT program. Okay? You do not need to be an AEMT to be a medic. If you want to be an AEMT, it's perfectly fine. I can't. I'm just telling them. Oh, whoa, whoa, whoa! I ain't drinking no haterade. This is a bang right here. All right, I'm just letting them know. You can go straight from EMT to paramedic, and some programs even just go straight to medic. But I don't know any of those by hand. But you have your EMT-B, optional AEMT for the most part, and then your paramedic. You don't have to go this route. I always recommend going paramedic, but I know a lot of great EMT-Bs and I know a lot of great AEMTs. So I would just leave it at that. The choice is yours. I like going just finishing it, right? But again, choice is yours. Maybe even get your EMT-B, maybe go for RN, almost the same time. The pay is really nice compared to an paramedic, but there's pros and cons to it. Like, we work for me at the fire department, I work 2 days on, 4 days off. That's a really great schedule. I'm able to do stuff like this, but it just depends where you work at. Let's see. Us got my hey, stop being a hater. Still learning, don't know my okay. Just got my EMT. Congratulations. A Wolf 13. I've been thinking about going to paramedic school in August. Great idea if I get in. Hopefully. And working as an EMT while going to school, is this a good idea? That's a great idea. You work with like-minded individuals, your work will usually work with you, and they may pay for some of your schooling. That's a fantastic idea. I highly recommend doing it. You can do it if you put your mind to it. Anything is possible. You can fly. I'm just kidding. Anyway, um, it's a little dumb joke. Uh, let's see. I hate being the bad child of EMS. You're good, Cool Breeze. We love you. I have my basic psychomotor test out on Saturday. Do you have any tips? I feel confident in my knowledge, but I am nervous. Let me see. I have my basic psychomotor test on Saturday. Okay. Do you have any tips? I feel confident in my knowledge, but I'm nervous. Remember your ABCs. What's going to kill them? Remember your vital signs. Know that you have 6 vital signs. Do them the same way every time. Blood pressure, heart rate. That's the heart. SpO2, respiratory rate, that's the lungs. Blood sugar, temperature, or temperature, blood sugar. Do it the exact same way every time. Do you think you know it? Okay, big game, big game. You know your 6 basic vital signs? Look away from your notes, look up and say them out loud. You'll quickly find out just how much you know and how much you don't. And then look at your notes, be like, oh man, I messed this up. Look away, say it out loud. Don't think it, say it out loud. So many students think they know until you do make them do that. Then they're like, oh shit. Give them a blank piece of paper. They're like, they want to look at their notes and they're like, maybe I don't know as much as I thought I did, unless I'm looking directly at the answer with my notes. So don't fall for that. Uh, know what questions to ask. Just remember your sample mnemonic. So signs and symptoms, allergies, medication or medications, past medical history, last oral intake, and events. And no OPQRST, onset, provocation, quality, radiation, severity, and time. Really, just knowing sample will carry you through 90% of these questions. And then know your medications, what you can administer. You'll be fine. I promise you, it's like not even 10 medications you need to know. Uh, I hope that answers it. But if you have questions, we can go through it. List all the departments which you work with and the coordinate with on a day-to-day basis. Okay, so I work 48 hours at Annabelle Fire Department, where I work at the bare minimum 2 out of 6 days. Ideally, I pick up an overtime shift or so, which is either 8 to 5 at Station 73, which is this one, or maybe I'll work a 24-hour shift somewhere along the week or two. Great, it's extra hours. I work part-time at Texas EMS Academy. And then for part-time for Texas EMS Academy, I'll work from 8 a.m. to 8 p.m. Or maybe I'll work just a quick 6 to 10, which is nice because it's easier on my throat. I used to work at Allegiance, which was a great private EMS company. They're really popular. but they have their pros and cons. But overall, I'm very thankful for the opportunity, and they have a bigger scope than I do at Ennisville. And I would work a 24-hour shift over there every now and then, maybe even a 48, but they'd have to be separate. It would be tough. Um, Meanwhile, I would put school in between those things. Sometimes for EMS or for YouTube, I'll put that in between. But you'll always find time if you just do some proper time management, or if you don't spend your time playing video games. You'd be surprised just how far you can go. And I still play video games every now and then, but really cut a lot of that out. If you find that you remove that, then you have more fun doing your other activities. It makes it really easy. Uh, so I hope that answers somewhat of your question. 48-hour shift and then 96 hours off gives you a lot of time. Gives me a lot of time to spend with my daughter too. So I really enjoy it, and I'm thankful that I have that opportunity. Let's see here. Got my NRMT coming up soon. Pretty nervous. Your videos have been doing wonders. Thank you so much, man. Have a good night. Well, I think I just cracked my finger. Ayume, fantastic. Don't be a stranger. You can always message in the Discord. We love having you. We love talking to you. It's in every single video description in YouTube video. But don't be afraid to ask any questions that you may have, and we will do the best of our ability, if not me, someone there, to help get you the answer. I'm going to create a test bank. It's on its final production. I would say give me 2 weeks. We got that thing live. But it took a lot of work. A lot of work. I've messed up my hand from it. It's okay. It's worth it for the grinds. But you'll see once it's done. It's going to be I think it's going to be the best EMT basic NREMT test prep in the market. Of course, I'm the one who made it, so I'm really biased. But I have a pretty good grasp of what EMTBs need to know. At least I think so. Let's see. Beefy Boop. You're still here, Beefy Boop? Uh, also, you got a crazy name. Also, I've started really considering fire after getting to talk with the fire department. They're super cool and helpful with questions, and they're very insightful. They are. They're great people. Uh, You know, I find that I've got a lot of stand-up guys that I work with and females that all try to push themselves. They work like crazy. I have guys who work like two other jobs while working full-time in a fire department. It's insane. But working with those people that are, I think, morally, we should somewhat be on a decent level. Um, Working around them helps kind of construe your own values and start to see from their perspective like the benefits of it. So I found nothing but pleasure working with the people that I work with, and I look at to a lot of them as role models. Mm. But yeah, keep talking, keep exploring those departments, and we actually have a job discussion thing in the Discord as well. Maybe if you ask about job opportunities, maybe someone can help you out. It's in one of the channels. Let's see. Oh, good to see you, Yumi. I saw the Discord pop up. I want to be like you when I grow up. There's pros and cons to it. All right, there's just as many pros as there are cons, but I would just take it as a compliment. Kelsey Wong, thank you. I would just take it as a compliment. We'll leave it at that. But I have just as many flaws as I do pros. You know, uh, just like even just as like a partner for like my fiance. Sometimes I can be good, sometimes I'm not as good, and then I gotta go buy food and apologize afterwards. And I had to do that uh, today. She's been working hard, my little sweetheart. But I can't wait to go see her after this. She's very sweet. She's a very amazing woman, and I got to work on myself a little bit. So just kind of thinking a little outside the box. Sorry. Let's see. I would know you work in a fire department. Do you have any insight for anyone who might think of wanting to go that route? Contact your local fire departments. Contact them and ask them, "Hey, I want to work at the fire department. What do I have to do? What are some prereqs? You guys do any volunteering? Can I stop by and say hi?" Uh, and just go from there. Communicating is the biggest thing. See what they're looking for. See what the prerequisites is. See if there's a way you can get your foot in the door. Maybe you can start working as a volunteer while you're working in school. Maybe they can pay the rest of your school off, depending on where it's at. It looks really great if you come in and I'm like, "Hey, I want to work at your department. I already have my EMT-B and I'm working on my fire." They're like, "This guy can already pass the test." And so maybe we want to help him pass this test and get him on before he goes working somewhere else. Maybe he's got a good or she's got a good moral character. or maybe they're working out a lot, and we want to bring them in. And so Annabelle paid for the rest of my paramedic school whenever I got hired on there, and they hired me on really quick. I was super thankful. I didn't even have to do an interview, which is pretty. I'm the only one I think I've ever heard not have to do one. But I was really lucky. Um, I think it happened right at COVID. I think I snuck in, which is good because my interview skills are kind of okay. Maybe I would have gotten hired if they interviewed me because I would have told them I'm not that great at fire. But I learned to enjoy it. Let's see. I hope that answered your question. If not, please let me know. I started my EMT. What are some of the biggest tips to be successful in my class? Have fun. Talk to your neighbors. Share contact information. Don't be afraid to share notes. Help someone who's struggling in your class because maybe they'll help you later on with a skill that you might not understand. Be friendly. Be kind. Don't. If you know more than someone else about a topic, don't be demoralizing to them. Be humble and be ready to learn. I just have fun and enjoy the enchantment of learning. That's all what I could recommend. What video games do you play in your spare time? I don't. I try really hard. I'm playing a little bit of Oblivion, the remastered. I cheated my way through like getting 70 sneak by like going in a circle and like I haven't gotten far. I just finished the Thieves Guild quest. I shouldn't be playing it. I've got a lot on my plate. I found a little bit of hours, but it's not good. All right, where you try to get away. But Oblivion's pretty fun. I play a lot of nerdy like indie games. I have a lot of fun with that. But I shouldn't play games. Okay, I struggle sometimes. And sometimes I'll watch a streamer play a game or something, and I'll be giggling or laughing. I watch Northern Lion a lot. Me and Colby's joke about it sometimes. He'll send me funny clips. If you have Northern Lion clips that you want to send me that are funny, if you send me them, I'll watch them and I'll laugh. So don't be a stranger on that. Uh, anyway, best stethoscope for EMTs. Heard the ones at the academy stink. They do. They do. They're plastic, really bad ones generally. The Littman is about $70. That's about as far as I'd go. I have a Littman and I found it to be really useful. Don't go any higher than 70 if you are going to buy a stethoscope. But and then even then, keep that on you at all times through school. Be ready if you lose it, leave it in a box that is going to get stolen. So don't go any higher than 70, in my opinion. Let's see. How do you feel about a medic carrying a pistol? Horrible idea. Horrible idea. Carrying a gun in the field, horrible. Usually protocols are against it. If we need to consider a weapon, we should not be on the scene. Police department should be on scene, managing that and making sure the scene's safe before we enter the scene. I don't need to be bringing a gun. Hopefully, I don't need to bring a vest unless I'm responding to like some type of mass casualty where I think that it's necessary. Uh, but I don't like to bring those. That's for police officers. I shouldn't be entering the if I'm entering the scene and I think I need one, I'm not doing my role properly. That's not my role. It's to wait till the scene is safe. The notes would say bleeding out is if it was because someone got attacked, till PD gets on scene and clears it, I'm not entering the scene. Because you know what? If I do and I get too eager, then I end up becoming another one of the patients. We have to wait for two incoming ambulances that are further away, and I'm not helping anyone by getting hurt. So protect yourself. Your life safety is the number one thing. Next is your partner. Then I think it's your patient, then it's everyone else. Uh, yo, I was a graduate back in January. Yo, I asked you about secondary drowning. Good, fantastic. Keep on keeping on, man. Very awesome. JS, secondary drowning. I'm kind of bringing it back. I think I remember talking about it. Are you talking about Texas EMS Academy when I was working there? Or are you talking about Annabelle? That's gonna kind of help me lean towards kind of the memory. But good. Asking questions like that shows that you're paying a lot of attention. And what is really interesting about secondary drowning is patients get pulled out of the pool. We save them. They're like, I don't want to go to the hospital. Well, maybe there's more fluid built up in their lungs that they don't know about. And then whenever they go back home, they lay down. Their alveoli gets filled up with or obstructed by the fluid that might be kind of out of the way whenever they're standing up straight, and they could end up having a secondary drowning event where they could end up dying that way or passing away. So let's see. Texas EMS Academy. Okay, I do remember you. Very cool. It's so good to have you, buddy. Uh, you passed your EMT, right? Hope so. If you didn't, let me know. I'll try to help you out. Congratulations, though, man. I remember you being very bright, so it's good to see. Um, anyway, secondary drowning is a very interesting topic. Let me catch up here. Second try? You're on your second try, or you passed on the second try? Let me know. Wav said, "Yeah, I had a squad for my EMT. Good, Wav, smart man. Working with teams on getting your EMS class done. Very smart. Did it? Good job, JS. That's exactly what I'd expect from you." Pyro, Jake says you're the goat. Hey, we're all goats here in this little field. But thank you. That's really sweet of you. Uh, Eric's Food Adventure. That's a cool name. I love watching little foodie YouTube channels. I don't know if that's what you're doing, but I should look, right? Let me see. They got 32 subs, but no. I love watching food channels. I'm such a loser. I'll watch somebody review over like Taco Bell or like something. They'll be like, "How do you like the new gordita wrap?" Mhm. And they'll spend like 8 minutes talking about it or 10 minutes, and I'm eating my food, and I'm like, "Ah, I get it. I get it. That makes a lot of sense. This is a good video." And so I eat that content up. I love anything cooking, anything food related. I'm all about it. I remove them all. Well, let me tell you, I would have loved seeing your content because I love watching that stuff. I'm a huge I can sit down and watch people eat and talk about food for hours. I can get more into it in a bit, but I love it. Let me catch up. Let's see. Become an IFT or intra-facility transport EMT, and I haven't practiced any of my 911 skills. I'm slowly forgetting some things. We were talking about that earlier. It's just part of the beast. Unfortunately, unless you do like secondary skills or you talk to your supervisor like or your partner, like, hey, let's practice or talk about some things, you're gonna forget some of your skills. It comes with the pay because you get paid a little bit more than 911, but it's tough, man. My best recommendation is searching for an outside source to kind of help propagate some of your skills, but you're always going to lose a little bit. And I'm sorry, but it's just kind of the beast of IFT. That's one of the big cons of it. Uh, Ayumi Jaden Mao, my instructor said the Littman Classic 3 stethoscope will get you through most of medical school. Yeah, $70 Littman scope, beautiful. Uh, and if you're in the Discord, maybe I can send you a link or something to something I could recommend afterwards. But just message me on Discord. That's the easiest way to do it. No problem, brother. Appreciate it. Hey, real sweet of you. We love helping each other out in all the comments. Uh, Mavis Div 3, what's your favorite color? Dark green, hazel green, all that is good. I guess dark green, forest green. I took the Jimmy said I took the NRMT today because I watched. I passed. I'm like dyslexic. I passed because I watched and learned from your video. Jimmy, good job. Good job, buddy. Time for a medic now. That's what we love to hear. That's from your hard work, Jimmy. You earned it. You sat down and you went through all that stuff along with extra content, and you earned that patch. So congratulations, Jimmy. I'm really proud of you. I used to do anatomy. Okay, we talked about the food. Personally, if you know self-defense, if you have weapon training and you're an advanced EMT, it's pretty cool. Thanks for the nice haircut. I read that too. You little sweetheart. I got it cut recently because I taught a fire stop the bleed course, and I was like, I want to present my department really well. Anyway, I don't know if you're asking me that, but I did used to do a little bit of boxing, um, but not so much sparring, more so just training. And I like the motions, like just practicing my punches was always really fun. Like practicing uh, popping your left foot there, but then retracting really quick, like twisting your body. Right. I thought that was really fun, but 99% of the time, you'll catch me saying, you know what, hey, to diffuse a confrontation, I'd be like, maybe I'm wrong here. I'll walk away. I I have too much. I have a family. I've got my medical license. There's no reason for me to ever try to be in a confrontation combat wise. Let's see. I should take the NREMT. I only got my New York State license. You should take your NREMT. You should get it done and then let me know how it goes. And if you have questions, let me know. I'll try to help you. Tips for an accelerated hybrid course. 2 weeks in person at the end of summer. Me personally, I like those courses. you're hitting it fast, you're interested the entire time, you're engaged, you don't forget anything because it's done like quick, quick, quick. And as long as you have to devote yourself to it, focus really hard, you can really excel in them. So I would recommend just having fun with it. Uh, okay, guys. Pass my NRNT. Julian, thanks for your study guide. Julian, it's thanks to you and your hard work. Good job, Julian. We love you, Julian. We're very proud of you. It's because you sought the extra resources and you did your own schoolwork. So, guys, I got to wrap it up. Closing time. This is my first time doing YouTube live. And let me tell you, I loved interacting with you guys. I thought it was super fun. This is definitely something that we're going to do again in the future. And let me know what you guys think about it. You can talk about it in the comments. You can talk about it in the Discord. Um, and I will learn, like, hey, maybe can we bring up this topic next time? Let me know, and we can bring it up and we can talk about it. This might be something. This is easy for me to set up compared to my other videos where I spend a lot of time on. Not saying that this doesn't take setup. I mean, look at all the stuff I brought. I brought a lot of stuff uh, because I respect your time and I want us to achieve a higher learning point at the end of this. Um, but we'll definitely do this again in the future. Maybe I'll give a bigger heads up. I had a blast. Interacting with you guys is so fun. And understand if I don't respond to some of your comments, I read them. I read every single one. Sometimes it's too hard to comment to all or respond to all of them. But I'm really thankful. I think we built up a really just an honest, great community that people just love medical information. And I just can't wait until we keep progressing, keep growing. I'm super blessed. We hit 7,000 subscribers. Uh, Thank you guys for all the love and support. And I get it like every day, and it's overwhelming. We'll definitely do this in the future. Leave some comments. What are we giggling? What are we giggling for? Let me read it real quick. Okay. Heck yeah, stream again. That's what I like to hear. First time watching your videos back. My first time here. Well, we love to hear you. And I'm a little foodie too. So if you're in the Discord, let me post the Discord. If you want to bring up about food stuff, I just want, let me say, Culinary Class Wars on Netflix. Fantastic show. And the best cooking show. I've watched so many cooking shows. Best cooking show ever. Anyway, love the streams. Super nice of you, Wolf. You guys have been super interactive. Please do it again. We're going to do it again. One thing, the camera should be flipped. Can't read the whiteboard? Yeah. Sorry, guys. May I'll take a photo and post it on the Discord, but that's a great point. We got to learn how to do that. Um, let's see. Anything else? I can't stream again. Clean the camera. Let me know in the Discord, guys. We'll adjust some things, and I'm gonna publish this video so it'll be available if you miss some things at the beginning, the middle, the end, or if you just like some background chatter because I talked for 3 hours straight. Let me know. We'll do this again really soon in the future, but we'll bring some different maybe equipment. Maybe if there's a topic that you want to hit or you think other people might be interested in, let me know. I'll write down a list. We'll work on flipping that camera. All right, but yeah, you had pads on the wrong side that threw me off on the cardiac sim. Sorry about that. Pads will go like this. Okay. Uh, if I'm here, pads will go like so for cardiac arrest. Only time you have to watch out for is like a external like defibrillator or a pacemaker or something. Watch out a little bit here. Watch out for any adhesive medication stuff. I'm rambling. We need to end it here. Thank you guys so much for watching. I will see you on the next one. Bye bye. Bye bye. Bye bye. Goodbye. Goodbye. Bye. I'll publish this in a moment. Ooh. All right. What the heck? Have a good night, you too.